गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यकलक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्र परित्रात्रे गुरुपाखण्डखण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि
सर्वराजाय गन्धाय सर्वगानश्रवणप्रणयिने गुणवते गणपतये
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय उत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यकलक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डखण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि
सर्वराजाय गन्धाय सर्वगानश्रवणप्रणयिने गुणवते गणपतये
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् 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 उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् 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 मृत्योर्मुक्षीयमामृता ऊर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृतात् त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् ऊर्वारुकमिव बन्धनान् त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् ऊर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृतात् त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् ऊर्वारुकमिव बन्धनान् 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 पुष्टिवर्धनम् पूर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् पूर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् पूर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृता त्र्यम्बकं यजामहे.
My association with Sir is because I'm proud to have to do the DM from that institute. And apart from his endocrine skills and the kind of teacher he is, today we went to one Vihar and Sir had the kind of photographs he took. That is again that shows his kind of interest and his versatility in lot many other areas apart from academics. And we have a distinguished speaker, Professor Dr. Sameer Agrawal, a very good friend of mine who's very near to my heart. And he was, we did DM together from All India Institute. And Sameer has got a reputation of reading a lot. He's a voracious reader. And we used to say ki, in our room, that Hostel 7, from All India Institute. And Sameer used to just keep on bringing those papers and used to have a pile up of papers. And हमेशा मैं ये कहता था कि यार तुम्हें तो ट्रक बुलाना पड़ेगा इस पेपर को ले जाने के लिए. And the way he used to put up rounds में, that he used to come up with this. And जब भी कहीं controversy होती थी, तो seniors कहते थे कि हाँ ये आप कहाँ से quote कर रहे हो. Sameer used to say, he is the topmost person working in this field, and see what he has written. So this kind of references. So I welcome Dr. Sameer Agrawal for the masterclass. So we have two distinguished speakers, and so not taking much of the time, as per our tradition, we'll go ahead with the first lecture. So I'm just trying to draw a picture about the present scenario and how to track the obesity. I still remember when there was 2001, 11th or 12th edition of Harrison's Principles of Medicine was actually launched. And it had one reference, the childhood obesity, 2% childhood obesity. 2% of the children are suffering in US with obesity. We used to laugh at that figure because that's something that that point of time we did not saw any kind of this kind of presentation in a clinical scenario. And see what has, now we have a separate lecture of approach to childhood obesity. Sameer will be taking care of that. So that is how the scenario changes. So it is very important to discuss about the tracking the obesity pandemic and the role of primary care physicians. Because dear friends, it is something which we all of us are seeing. So non-communicable diseases are the leading cause of death and disability globally. 74% of the global deaths in 2019 were due to non-communicable disease. This is the WHO data. And obesity is a bigger threat among non-communicable diseases in India. And 46% obesity, 33% hypertension, 26% type 2 diabetes. So it is something even beating diabetes. And majority of, in my clinical practice, and majority of you will also agree, out of 100, majority of my patients are from the female, they are the females, and out of them, 80% are obese. So this is something, my data is anecdotal, but if you'll go for a study, this is something which I expect it will come. So the prevalence of obesity among adults is 650 million people with obesity across the world, and greater than 135 million people live with obesity in India. That is something very alarming. It remains the undiagnosed and undertreated thing. People living with obesity, 100%, and again, this is a problem. Why not it is reflecting over here? So, people living with obesity, again, people diagnosed with obesity, people receiving evidence-based anti-obesity treatment, that is less than 20%, and people prescribed, those who have been given anti-obesity medication. Whenever we prescribe a medicine for obesity, people are concerned, डॉक्टर साहब इससे कोई नुकसान तो नहीं होगा. तो most of the times मुझे उनका कहना पड़ता है आप तो फायदे के लिए आए हैं. You want to lose, and obesity is going to create problems for you. But this is the kind of persona, or we'll say the kind of picture which has been painted in a black color regarding the drugs relating to obesity. People are scared about those medicines. So the role of primary care physicians, recognizing the obesity as a serious chronic disease, perceiving the benefits of weight loss, and identifying current unmet needs in obesity care, and importance of obesity-specific medical education. These are the things which I'll be covering. So role of the primary care physician is first and the foremost is recognizing obesity as a serious chronic illness. So the obesity meets common criteria of a disease, the definition of a health, a state of complete physical, mental, and social well-being. So as an impairment of normal functioning of some aspect of the body. So these are the things which are met by obesity: appetite dysregulation, abnormal energy balance, endocrine dysfunction, infertility, non-alcoholic fatty liver disease, dyslipidemia, increased body fats, symptoms associated with increased body fat, including joint pain, altered metabolism, sleep apnea. In fact, it is covering every now and then the second or third patient is suffering from this problem. So this is something which we did not had. I was quoting some 20 years back when we were students, we were doing post-graduation. That was something, it was not the picture like this. So in the last 20 years, dear friends, the scenario has turned towards this, and now we are talking about obesity as a disease. So it's a recognized both as a disease and a chronic clinical condition world over by the World Obesity, AMA. These are the societies now which are, there is not just single, they have pointed out it is a disease and it has to be handled properly. So obesity is associated with multiple complications. We all know about the metabolic one, the mechanical, mental. Apart from that, depression, anxiety, asthma. There are so many things which we are suffering because of obesity. And sleep apnea itself is an entity which demands a separate masterclass. So that is something, because majority of my patients, they have this problem of sleep apnea. And when we diagnose them effectively and when we address the issues upfront, so the response is tremendous. So this is how the scenario is. Cardiovascular illness, we have been talking about them since so many years. Coronary heart disease, chronic back pain, type 2 diabetes. So there are so many things which are being associated with obesity. And so the role of primary care physician is very important. So perceiving the benefits of weight loss, the greater weight loss leads to improved health outcome. The patient may say, Doctor Sahab, मैं वजन क्यों कम करूं? Because it will help in hypertension and hyperglycemia. So it is again 5% benefit. Prevention of type 2 diabetes, non-alcoholic fatty liver disease, PCOS, dyslipidemia, cardiovascular disease, urinary stress incontinence. There are so many things which are being benefited, the overall improvement when you lose weight. So weight loss reduces the risk of type 2 diabetes over 10 years. In patients with obesity and pre-diabetes, the data is very clear. And it is in one arm, the patients are on metformin, the other it is lifestyle modification, and the placebo, the green one is placebo. So there is a stark difference between the outcome when it comes to lifestyle changes and drugs for obesity and diabetes. So the progressive weight loss has dose-dependent and tissue-dependent biological effects. The benefits of 16% weight loss is like liver insulin sensitivity, liver triglycerides, again this reduction in liver triglyceride, beta cell function, they improve, muscle insulin sensitivity improves, gene expression for adipose tissue again is there, abdominal adipose tissue, there is again decrease in that, adipose insulin sensitivity and inflammatory markers. So see the parameters when you lose weight. And majority of the times, 5 to 10 percentile weight loss is something which brings this kind of benefits. So this is something, a huge benefit with little bit of efforts from our side. This is what the treatment of obesity is. So the role of primary care physicians, again, needs to identify the current unmet needs in obesity. What are the unmet needs for physician? The unmet needs in obesity are lack of recognition as a disease. हम तो खाते पीते घर के लोग हैं, majority of the times this is the scenario. कहीं आप टोको तो this was a scenario which we used to face in our clinical practice, but now somehow the awareness is improving. Limited efficacy of pharmacotherapy, this is there, and apart from that there's a lot of misconception regarding the medicines which are being approved. Conservative treatment, majority of the times हमें लगता है कि obesity treat करना is for some particular apps or kind of things, the things which are being circulated throughout in the Facebook and all. And yesterday only I saw a पर्चा in one of the newspapers कि 3 दिन में वजन कम करिए, नहीं तो पैसे लौटा देंगे. So this is our, and we are being carried away by those things. Even I met some doctors. There are some big Ayurvedic concerns and startups. They went to those places. Dr. Saab, I also went to that place. And this is the kind of statement which I get from even learned doctors also. Because somehow, somewhere, we don't recognize obesity as a disease. And we always look for alternative pathway. So unwilling to talk about obesity is also a big issue. Patient, the moment patient will come to you, patient बोलेगा मुझे सूजन आ रही है. Majority of the time, the ladies who come to us, कि डॉक्टर साहब मैं सूजन से परेशान हूँ. और सारी विवेचना आप करोगे, पीडल एडिमा नहीं, nothing, there is no problem. She doesn't have any cardiac problem. She doesn't have anything. And when I say कि ma'am this looks like obesity, somehow somewhere there is a kind of they get disheartened. क्योंकि सूजन तो बीमारी का पुट है, और you always say, but obesity खुद की गलती वाली बात भी आ जाती है. Fortunately in India अभी हम बात कर सकते हैं. In US and West तो आप गलती भी नहीं बोल सकते आप. So this is how the scenario is. So lack of recognition of disease is a big problem. Only 36% of individuals with obesity were diagnosed as per the Action of 10 study, and the greater decrease disease awareness among healthcare physicians is anticipated to change this. So we need to have this approach inculcate this approach among the physicians. So the limited efficacy of existing pharmacotherapy is also a problem. Lifestyle medication, 3 to 5% of them are following. Pharmacotherapy, 3 to 10%. And there are hardly people who go for the gastric bending, gastric sleeve and all, and bypass. So this is how the scenario is. So insufficient weight loss with conservative treatment, low calorie formula diet, behavioral therapy alone, so there are limitations when it comes to treatment also. So unwilling to talk about obesity is again an issue. Time for weight struggle to healthcare physician. Age when struggle with weight gain, that is 33 years mean, most of the times they do. And the number of years between when struggle with weight began and first discussed with healthcare physician is around 6 years. So age when first discussed weight with the healthcare physician around 38 years. So at the age of 38 years, they think now we have got something which needs to be addressed by a proper doctor. So this is a problem, the unmet need. And reasons for not discussing the weight management is, I believe it is my responsibility to manage weight. They see it as a personal responsibility. The appointment is not long enough. I do not feel motivated to lose weight. I'm not interested in losing weight. There are many reasons. There are more important health issues to discuss. I do not think my healthcare provider is interested or concerned with my weight. This is a very genuine problem. Majority of my patients who come to me, they come for treatment of diabetes. I try to develop interest regarding their weight also. Somehow, somewhere, डॉक्टर साहब आप तो शुगर ठीक कर दीजिए, बाकी चीज़ों के बारे में रहने दीजिए. So most of the times, husbands इस तरह का रिएक्शन देते हैं. उन्हें लगता है कि ये डॉक्टर साहब कहीं और जांचें न करा लें. This is again that kind of attitude is there. So the fallacy lies with us कि हम इतना interest generate नहीं कर पाते. In clinical practice, this is what I'm facing, and this is something which is common for most of us. Feelings after most recent discussion of weight with healthcare physicians. This is again a data, positively, again motivated, hopeful, supported. This is the percentage of data which has been generated from around 8,000 patients. So we need to take action. Half of the people with obesity are waiting on average of 6 years before seeking for help from the healthcare physicians. This is quite alarming. Around 2 of the 3 people with obesity would like their healthcare physicians to start the conversation about weight gain. So, initiation has to come from our side. They will definitely expect कि you will point out towards their weight, but you might be ignorant, or you might will आपका past experience रहेगा कि why to touch things which are not been actually asked by the patient. So this is not there. And however, healthcare physicians think that only around 1 in 3 people with obesity are motivated enough to lose weight. So motivation is also a very good medicine, a very effective medicine, and that actually demands a lot of conversation and a lot of talk. Most of the times, majority of the times, we don't have that much of time. So to summarize, the statistics of obesity is alarming in India. Obesity is not mere lifestyle disorder. It is a serious chronic disease as recognized by numerous global scientific bodies. It is proven that obesity can directly lead to increased mortality as well as contribute to higher risk of myriad associated conditions. Greater the weight loss, better the outcomes. Weight loss reduces the risk of type 2 diabetes over 10 years. So lack of recognition of obesity as a disease among both patients and healthcare physicians, limited efficacy of conservative treatment options, unwillingness of the patient to talk about their weight constitute the current unmet need in obesity care. Thank you. Thanks a lot. So, after creating again this, I will like to invite Dr. Samir Agrawal. He'll be talking about approach to childhood obesity. Dr. Samir, the stage is yours. So, what is your take on this, sir?
We were always describing the thin fat Indian, which is also there, who are also there, the thin fat Indian. But the fact is that just the fat Indian, at least in larger hospitals, relatively more affluent clientele, more affluent patients, is like all around. So if you talk of type 2 diabetes, we analyzed this about 10 years ago, and at that point, 85% were clearly overweight, not borderline or anything, and a significant proportion was obese. And I think that figure will be even higher now, considering the number of people in the 20s and late teens that we are seeing now with type 2 diabetes and obesity. So I think you're absolutely right, Sachin. It's very important to drive the point that obesity is driving your diabetes. Patients don't connect. They don't connect that. They think sugar hai, alag hai. But actually it's obesity, and people say that if you can get rid of the obesity, then 80 to 90% of type 2 diabetes will disappear.
Previously, there was a time when people used to say कि सेठ सेठानी मोटा हुआ करते थे. Nowadays, that particular triangle, it has upside down हो गया है. Nowadays, those who are from the middle class and lower strata, that is something. What is your take on this, sir? What might be the reasons behind it, sir?
That is the Western pattern. In the US, the upper socioeconomic status is not obese. They're very conscious that lean food is more expensive. The cheaper foods are all high fat and high calorie. And if you go through the New York subway or anywhere, it's and the data, of course, that it's the lower classes in the US, lower middle kind of classes that are maximally obese. And the same thing is happening here.
So,
If you did a small study on our chauffeurs in metros, drivers, who almost always migrate from smaller towns. In Delhi, it's mostly UP and Bihar. And within 3 months and they come really skinny and almost malnourished. Within 3 to 6 months, they all have bad waist-tip ratios.
that's true, sir.
Quite simply because the diet changes and physical activity goes down.
Majority of the times, they are being not fed with the kind of family food. They survive on this. They thrive on kachori, samosa, and all those things. And they are actually, we need to bring this awareness to that level. So, Samir, now the stage is yours.
Thank you, Sachin. Always nice to be in Bhopal, and I think every time Bhopal shows a new challenge. Dr. Ambrish was also telling me today, beautiful city, and I think the view from the hotel and hotel itself seems to be a new property, and I think the best. So I have been to Udaipur and other places also, but there is something into it. Of course, I have a bias for Sachin, so but it's a privilege to be here and honor to be co-speaker with Dr. Amrish Mittal, who is the stalwart, and he's a Amitabh Bachchan for us. And sir, I think he's a brand ambassador along with Kapil Dev also for obesity, something I keep on reading some posts also. So I think obesity is definitely being talked about, and the noise is being generated recently for obesity. And I was reading some papers also for diabetes also. I think very important to talk about weight management. And we are now having those treatments who are targeting on HbA1c and also who are targeting on weight also. And I think the story starts from childhood. And there is a good amount of data which is showing that not only in urban areas, even in rural areas, we are seeing more and more pediatric obesity. In fact, we did one study for analyzing IGF-1 levels in urban and rural population around Rohtak. The paper is still under publication. We took around samples of 600 children, and there was around 10% overweight and obesity rate in urban areas, and around 7-8% overweight and obesity in the rural areas around Rohtak area also. We will be coming out with this normative data shortly. This was the thesis for one of our postgraduate students, and I was the co-guide. So we'll come out with the results maybe next time. So important to talk about evaluation and management of childhood obesity. So you can see this. These has been the figures from India, published in 2006 in Indian Pediatrics, overweight and obese children among school children in Delhi. But I think this shows the private school boys have been around 17% overweight, and also 19% for the schoolgirls being overweight. So this was the famous diagram. We all have shown that in spite of being the same BMI, this is Dr. Yajnik's many years back photo. You can see the BMI is same, but we have more fat. So I think we need more and more studies. And of course, last week we were all together along with Dr. Amrish. He looks almost same. So both parents, 9% risk for childhood obesity, and both parents obese, 60 to 80% risk for obesity. So very high figure for this. And we were talking about maternal programming. I think if you are exposed to certain environmental and nutritional things at certain discrete point of time, maybe it puts you at risk for being overweight and obese. In fact, there was a good study published in Pediatrics in 2006, where those women who had underwent bariatric surgery before getting conceived, they were compared with around 40 to 50 children who were born to those mothers who didn't undergo any bariatric surgery. At 6 to 12 years, those women who had underwent bariatric surgery, the offsprings were normal weight. They were not overweight or obese. So something to suggest for, I think gestation is the best period where you can talk about this maternal programming. We are not yet sure why these things are happening, but this is, I think, one of the very few papers published in Pediatrics 2006 talking about the weight of offsprings for those mothers who had underwent bariatric surgery. So how do you define obesity in children and adolescents? Usually for adults, like we say, if you have a BMI more than 27 to more than 27, you are being labeled as obese. For Western population, we say if it is more than equal to 30 kilogram per square meter, you are being labeled as obese. And for overweight, 23 to 27 for the Asian cutoffs. But for children and adolescents, I think the standard guidelines take into account the BMI percentiles. So for endocrinologists, we always keep with us BMI percentile charts in our clinics whenever we are talking about overweight and obesity in children. So if you are from 85th to 95th percentile, that usually says that the child is overweight. And if you are more than equal to 95th percentile, that suggests that you are obese. So the treatment managements, the approach, stepwise approaches, whether the child has to be subjected to counseling and dietary therapies, or child being subjected to any pharmacotherapy or talking about surgeries, it all depends upon the underlying BMI percentile and also the comorbidities. So this is the definition. If you are more than equal to 95th percentile, the child falls into obese. So another thing we talk about is severe obesity. So if any child is having a body weight which is more than equal to 140th percentile of that 140th percentile for the 95th percentile, or I think recently they say if the child is more than equal to BMI more than equal to 40 kilogram per square meter, then the child is severely obese. And many guidelines or statements are talking about you can consider these children for surgeries also, provided they have undergone counselings, behavioral modifications, and sessions for 3 to 6 months. So whenever we encounter a child with obesity or being overweight, we have to take a proper history regarding the age of onset, any history suggestive of any causes or comorbidities, family history. Like I told you, if both parents are obese, then there is a high chance the child will be obese. Any history of medications, history related to any systemic disorders, psychosocial nutrition, and one thing is very important, the screen time these children are being subjected to online activities, on the nets. So physical activity, whether the child is being engaged into and which sort of physical activity the child is being engaged to, not just standing outside in a park and doing nothing. So you have to take into account all these things and then plan your management. So you have to do assessment of nutritional factors related to childhood obesity. So this is all in the list, but important thing is that skipping the meals is not good for the child, and there is a data which has clearly suggested that child who eat less frequently are more likely to be overweight and obese than who eat frequently. So it's important not to skip. Maybe it leads to some compensatory overeating also. So assessment of physical activity, the hours they are spent on television, and the physical activity behaviors, frequency, duration, and intensity of the physical activity is very important. Which sort of sports the child is involved into. The drugs, interestingly, many drugs can cause weight gain. Practically what we encounter in our clinics is females who have been taking anti-epileptic drugs, I feel they can cause weight gain. Antidepressants can cause weight gain. A lot of adults are taking, and that can be one of the causes. Of course, steroids can cause weight gain. But you have some drugs which are antidepressants and they do not cause weight gain, but they are in fact cause weight loss. I think venlafaxine is one of the drugs which is commonly used. It doesn't cause. Topiramate, it is in fact sometimes used as a weight loss agent also. So if you have a child who is suffering from epilepsy, seizure disorder, I think these group of drugs like topiramate will be beneficial for them. Of course, you have to rule out any underlying conditions, like we should rule out any renal calculi, and glaucoma I think we should rule out before putting a patient on topiramate. So drugs leading on to weight gain, antidepressants, olanzapine. Olanzapine is I think one of the drugs which leads to not only weight gain but high blood glucose values also. And we have seen sometimes just stopping this drug leads on to improvement in blood glucose. So anti-epileptics like carbamazepine, valproate, frequently used, these all can cause weight gain. Sometimes you have a child with abrupt onset obesity. Usually you have a child who is saying, or the parents are saying the child is having obesity or being overweight since many years. So these are the things which we must rule out. I think endocrine causes like Cushing's, sometimes hypothalamic tumors. So these are important things. Recently patients started on drugs like corticosteroids are important. Of course, you will have other signs of hypothalamic disturbances, and Cushing's will show its own signs and symptoms, but yes, these can be causes. In children, Prader-Willi, that can cause rapid weight gain, but of course it's associated with hypotonia, short stature. It presents sometimes at 1 to 2 years of age also. Family history you have to take, and the psychosocial history is important. And I think I was reading through the article today morning also. The vaping, I think, is being quite prevalent, not only with adults, but I think in schools. There were 3 boys who were caught with vaping in my daughter's class last month. So it's a serious issue. My daughter is in class 9th at the moment. And I think she was already telling me, and we couldn't believe that this is happening in schools. And we are ignoring these things, but I think it needs an alert for all of us, what's happening with our kids, and whether there is tobacco abuse, alcohol abuse, or vaping. These are all risk factors putting these children at risk for being overweight or obese. So depression has to be taken care of, and it can be a both phenomena, depression leading on to eating disturbances, and again obesity leading on to depression. So once you have taken an elaborative history, rule out any underlying systemic illness or some drug history, we can go for an examination. Practically, this is what we do, check the blood pressure. I think it's very important when we talk about blood pressure in children or adolescents, it has to be a proper cuff. And frankly, accepting, I have these cuffs in my OPDs, but it needs time and it needs that equipment to be there. The width of the cuff should be, I think, 40% of the arm circumference, and the length should cover around 80 to 90% of the arm circumference. That should be the guideline for an appropriate blood pressure cuff. And when should you label a child as hypertensive? I think till adolescence, like 16 years, if it is more than 95th percentile for age, sex, and height, and if it's a more than 16 years, if any adolescent is having a blood pressure absolute values more than equal to 130/80, that falls into hypertension. Of course, you have to do a repeated readings. For children, it is recommended that at least 3 readings at 3 different point of times with appropriate cuff. That falls into the definition of hypertension. And in fact, hypertension is the most common comorbidity which is seen in children with obesity. BMI percentile, have a quick dermatological examination, chest, CVS, and abdomen. You can check for any hepatomegaly because fatty liver disease can be frequently associated. Have a skeletal examination because some skeletal abnormalities can point out towards underlying systemic causes for obesity. It can be a polydactyly, it can be a genu valgum and verum. Pubertal status is very important. We have seen males to land up into delayed puberty, and many hypothalamic and pituitary causes for obesity can present with either delayed puberty, and sometimes it can be presenting with even precocious puberty also. So very important to check the testicular volume in males, in boys, and check for breast development or do a Tanner staging for girls. Why it is important to check for Tanner staging in girls is that I think they can land up into precocious puberty, girls with being overweight and obese. Usually the average age of menarche is around 11 years, but we sometimes see girls presenting at 9.5 or 10.5 years with menarche. So obesity and being overweight is a risk factor for precocious puberty or early menarche in girls. But for boys, I think it's opposite which happens. If they are being overweight and obese, it's a delayed puberty. So why it is a delayed puberty, still we are not clear, but maybe being overweight and obese, their testosterone gets aromatized to estradiol, and that inhibits LH and FSH in the pituitary. So maybe it's responsible for that. You can have these skeletal features, skull circumference, microcephaly. Eye examination, any clues on eye examination, like you can have, if a hypothalamic pituitary lesion, it can present with visual complaints, nystagmus. fundus is important not only to rule out any other pigmentary changes in the retina, and sometimes blurred disc margins may indicate pseudotumor cerebri. Look for skin features of hypothyroidism, stria and ecchymosis. In fact, most commonly, the stria which we see in obese child, these are normal stria related to obesity. But if you have a stria which are more than 1 centimeter in diameter, they are pinkish, dehiscent, I think we must rule out Cushing's or exogenous steroids. Acanthosis is, I think, one of the frequently encountered complications which we see in obesity, not only in children and adolescents, but with adults also. It is suggestive of, acanthosis is suggestive of insulin resistance. It can be suggestive of polycystic ovarian syndrome in females. Hirsutism, again, if you encounter any girl with hirsutism and she is obese, she can be suffering from polycystic ovarian syndrome. She can be on sodium valproate. So she can be, sometimes they just present, Cushing's just present with obesity and hirsutism. So it can be an underlying hormonal disorder. So consultation with Dr. Sachin becomes very important if you encounter such children and adolescents in your clinics. So these are, I think, important things when you encounter hirsutism. Skeletal things like polydactyly, slipped capital femoral epiphysis, we have encountered couple of cases. And in fact, what I understand is that from endocrine point of view, slipped capital femoral epiphysis, couple of things which we have to rule out. One is obesity and sometimes hypogonadism. That can also present with slipped capital femoral epiphysis and Blount's disease. Vitamin D deficiency accompanying obesity can also cause genu varum and valgum, but this is one of the conditions which can accompany Blount's disease, overweight or obese children. Genital examination is important, like I told you. Delayed puberty, small testicular size, absent puberty can suggest you sometimes underlying systemic disorders. Prader-Willi syndrome, Bardet-Biedl syndrome, leptin deficiency, and leptin receptor mutations can all be associated with obesity and genital issues, so you have to do a proper genital examination. These are whole list of features which can suggest you that there is something abnormal. I think out of these, short stature is very important. Any obese child or where you have a short stature, usually what I see in our clinics is that obese males or females, they are tall stature. Maybe the hyperinsulinism which is there with obesity, that stimulates skeletal maturation. But if you have a short stature, you must rule out Cushing's. That's very important. Or sometimes in neonates or infants, Prader-Willi can be associated with short stature and obesity. So depending upon these features, I think you have to take out your book and again come back to Sachin. So lab evaluation is important. You have done a good history, checked the blood pressure with proper cuff size, and you have tried to make out something in a child, and then you must do some basic investigations. I think hemogram, thyroid profile, blood glucose, fasting and PP, and maybe OGTT. Liver functions are important, vitamin D and lipid profile. Additional testing, like if I am suspecting Cushing's, then what test you can do is, anyone from the audience? If you want to rule out Cushing's disease, if you want to rule out exogenous Cushing's, the best thing is to do a morning cortisol at 8 a.m. It will usually be suppressed. If it's raised, or sometimes we have seen cortisol even in the normal range, and the child is highly suspicious for Cushing's, always do a overnight DEXA suppression test. So, depending upon the features, if you are suspecting PCOS, then you can do a testosterone in the morning state and look for the levels. So, I think depending upon the underlying differentials you have kept into mind after a history, then you tailor your investigations according to the things. So, complications can be whole lot of in a child. That is why we want to address this. It can be diabetes later on. Insulin resistance have so many things. I think clinical signs of acanthosis, but HOMA, IR index, quick index, and fasting glucose insulin ratio. These can be markers for insulin resistance. If it's a HOMA IR which is more than 4, that can be suggestive of insulin resistance. I think more of research settings tests, these are being done. Hyperandrogenism, you do a testosterone, it can be, obesity can be associated with pubertal issues, hypertension, dyslipidemia, some cardiac issues can also crop in. I think this is very important, and we had a talk on this also in SpeedCon last week, non-alcoholic fatty liver disease. So interestingly, I had this concept that normal AST and ALT should be around 40. Dr. Sareen was there from ILBS. He suggested that he is taking normal levels of ALT and AST to be around 20 to 30. And in fact, I dig out the literature last evening also preparing these slides. There is a paper published in Gastroenterology 2010 where they say upper limit of cutoff 22 for the girls and 26 for the boys. Sometimes you can have underlying NASH and AST and ALT will not be disturbed much. So you should have a high index of suspicion for NASH. And other tests like fibroscan or elastography can help you out, but I think Sachin will be having the talks on this aspect maybe in the next masterclass, but important comorbidity which can be associated with pediatric obesity and overweight. Orthopedics, like I told you, slipped capital femoral epiphysis and the Blount's disease. In fact, for adults, we say that the obese adults, they have a high bone density, but not with the children. In fact, their bone mass is less and they are more susceptible to fractures. And secondly, vitamin D deficiency accompanying overweight and obese child, since vitamin D is a fat-soluble vitamin, can also put them at risk for fractures. Idiopathic intracranial hypertension and dermatological manifestations we discussed. So these are the typical signs for acanthosis: neck, axilla. This was one of the cases which we encountered few years back. 5-year-old boy, significant weight gain and BMI more than 97th percentile. In fact, he was suffering from this MC4R gene mutation, single gene mutations. And in fact, we have this sematolonide, which is, I think, being given to these children for MC4R gene mutation, not available in India. So these can be single gene defects which can be associated with obesity. Another case which we encountered in Rohtak, again, I think last year we encountered, he was having, the concern for the mother was small penis and child being obese. BMI was high and the child was, in fact, if you see the height, it is short stature. So I think this combination doesn't go along. You have to have something into it. And the weight, this is the normal growth chart. And there was some not exactly nystagmus, but long shallow philtrum and bitemporal narrowing. And there was strabismus in the eye, clearly visible. And this was another feature, like I told you, good skeletal examination. This was having 6 fingers or polydactyly. And interestingly, in the feet also. So we read the combination of these. There was genu valgum and intermalleolar distances were also high. Micropenis was definitely there. Any newborn child who has a stretched phallic length of less than 2.5 centimeter falls into this. And this was, so we suspected Bardet-Biedl syndrome. And we did a fundus examination. We didn't catch up. Then I discussed this case with the consultant from ophthalmology. And this is what we find out, bony spicules. These are very rare cases, very few cases reported from India also. So retinitis pigmentosa and bony spicules. So diagnosis was clear and this child was fulfilling all the criteria for Bardet-Biedl syndrome. So these can be various syndromes. We cannot remember, but we can always go through the literature. So the comorbidities we had discussed, and the management, I think, again, it involves a lot of talking on this, but just to be brief, I think important thing is counselings. And not only counseling for the child, I think it should be a collaborative counseling where parents are taken into account, and it should be a multidisciplinary approach. Maybe you need a help of a counselor also, psychiatrist also. So depending upon the weight and BMI percentile, you always begin with step 1, and then you keep on increasing your steps depending how the child is responding to counseling, diet, lifestyle changes. I think these are very important things, because addressing the behavioral issues or putting the child for dietary and lifestyle changes will be a long-term solution. Rest all are short-term solutions. So these are very important. For refractory obesity, or where in spite of subjecting the child for sessions and counselings for 3 to 6 months, still there is no improvement in the BMI percentiles, maybe you can consider for pharmacotherapy. So surgical therapy also is being talked about these days. Pharmacotherapy, I think there is a lot of interest being driven for semaglutide. I think it's approved in US for children more than equal to 12 years of age, once a week semaglutide. These are other drugs, like Orlistat is approved for more than equal to 12 years. Phentermine is also approved, not available, I think, in commercial market. Phentermine is approved for more than 16 years, and interestingly, if you have a phentermine and topiramate combination, they have approved for more than equal to 12 years of age. But I think we rarely used any of these therapies in children and adolescents. I think most important is to have a supervised training schedules. We ask the parents to accompany their child if he is going to gym or some stadiums to check whether the child is being engaged, have a proper dietary regimens, and cut down on the screen time. I think these are very important things. It should not be more than equal to 1 hour, 60 minutes for the screen time, whether it is mobile phones or working on their laptops. I think these things are more important, but these are some list of the drugs which are being approved. Weight loss surgery is being recommended by bariatric surgeons, but again, the literature says that if you have a child with severe obesity, weight more than 1/40th% of the 95th percentile cutoff, or more than equal to BMI more than equal to 40 kilogram per square meter, maybe you can discuss sleeve gastrectomy or bypass surgery, especially if the child is having comorbidities. So these things are definitely dramatic improvement is seen, like type 2 diabetes, OSA, NAFLD, and interestingly, albuminuria regression was also seen in those cases who were severely obese and had albuminuria. So male hypogonadism can improve, but if the child loses weight by diet, lifestyle, and nutritional methods, I think all of these things will also be taken care of for in that case also. So I think measuring BMI and BMI percentile periodically is very important whenever you are encountering children. Assess obesity-related risk factors, and referral to a comprehensive weight management program is of paramount importance. Thank you all for your patient hearing.
You must have talked about the metabolic reprogramming, sir. So please go ahead, sir.
I will just like to ask you one thing, that in last 2 or 3 decades, India has been seeing, as you have very rightly mentioned, not only childhood obesity, but obesity per se is rising. So what is the role of environmental pollution into it? Because what I think, during green revolution time, so much of insecticide, pesticide, fertilizers, they have been pushed into our soil, that they are now finding the place in circulation, and all the water bodies, including land, is full of these chemicals, and they have got estrogenic potential, which we call as xenoestrogens. So what is your understanding? Are we having this epidemic because of this highly contaminated water and even soil, because many of these chemicals, they are non-dying, they are non-perishable kind of thing. So they keep on circulating. So our entire water bodies, which we are using, whether it is well or it is tube well, and including land, which is full of chemicals. And every day we are pumping chemicals as a spray for insecticide, fertilizers, pesticides. Now, not only that, as contaminant, because every food item which we purchase is contaminated. Take it for granted, whether it is masala or it is khoa or it is ghee, everything is contaminated.
Thank you, sir.
Whether this rise in incidence of obesity in adults as well as in childhood is because of this environmental concern.
Thank you, Dr. Mishra. Always alert and always feel like giving a viva. So we always accompany one senior like Dr. Mittal with us for these things. So I think, luckily, and I read this yesterday evening, so I can answer. It's a fresh memory for me. Two things have been related with what you are calling endocrine disruptors. One is DDT, and second is bisphenol A. The scientists and the literature is still not clear whether this is associated with obesity. But the levels of bisphenol A were found to be more in obese children and even in overweight children and adolescents. One thing was said that maybe because these are all fat-soluble chemicals, so that can be one of the reasons that it's a simple association and not a causation. So endocrine disruptors can cause hell lot of endocrine issues. Maybe it is delayed puberty, precocious puberty, recurrent abortions. We are still not clear. I think we require more and more data and more studies on this aspect. But these are the two chemicals which have been associated with obesity and endocrine disruption, DDT and bisphenol A. That is why now I think we are seeing the water bottles for kids where it is written that it is bisphenol free and all these things, but we are still not sure. Yes, sir. This is the Indian data, sir, in fact. So that is what I was talking about. Even in our cohort of around 600 children, we also found that rural children had a little bit lesser incidence as compared to urban and also private as compared to rural. Sir, maybe the physical activity of the rural children is better. Yes. Yes, very right. Yes.
Mic दे दो.
Very right, sir. That is why we need to talk about more and more for childhood obesity, and we need to tailor our government programs hitting at this level. Yes, sir.
It's very true, sir. Very true. Yes, last week only we had an opportunity to hear Dr. Yajnik. He was also talking about that, sir. Mittal has to say something.
You're absolutely right, sir. And even now the difference in obesity between government and private schools is very evident in Delhi. By and large, all middle-class children go to private schools. It's only the BPL and some very limited people who go to government schools. And there is a basic difference in nutrition. If you were to study malnutrition in government schools, you'll find it much higher. So it's basic nutritional deficiency, change in lifestyle. And although, again, both in government schools as well as in rural areas, obesity is increasing there too. But the difference is very much there. It's multifactorial. It's the family background. The family, it's not that the child alone is overweight. Most of the time when the obese child comes, the family parents are also overweight, at least one of them or sometimes both. So it is very much to do with the family. And then, of course, once I was doing a program with students on, I think it was Doordarshan or something, and free questions. So they said, you're giving us so much gyan about diet and what we should eat. Where is that available? In our schools and colleges, what we get is all the samosas and kachoris or the burgers or whatever, that's what we get. So what should we do if we really want to eat healthy while we are studying or while we are at college? So the thing is, it's our responsibility, society and government, if not just government, everybody has to pitch in to provide the correct options to this thing and actually remove unhealthy food from schools. And that's an area where you can do it. Adults may say choice, this, that, but in schools you can just implement it and not have unhealthy options at all. But it's a little bit more expensive, a little bit more work. So that is the question. Oh, of course, yeah. I didn't say that. Yes, absolutely.
Children are busy with their, laptops and this and that.
Absolutely. So absolutely, there are so many better distractions, more attractive distractions now than they used to be in our time. So people don't have, they have so many choices. So I guess that is absolutely true. It's probably higher now, sir. It's probably higher now.
See, nowadays, getting a chocolate used to be a lot of, we used to run after our parents कि मुझे वो chocolate खानी है. Now, yeah.
And night food, you know this, I'm sure it's here in Bhopal too. For students, they have night food service. So if you're in Delhi, so if you're studying at night, you can order food 1 a.m., 2 a.m., whenever. The people keep eating and studying.
But in continuation, just I was there last week in Delhi. Dr. Khargawat just told me, he's from All India Institute, is my teacher. They have removed that legendary samosa, which used to be very famous from All India canteen. It has been replaced by millets. So this is an international year of millets. So jwar, bajra and all. Sir, please. It's true. Very true, sir. Sir.
Yes, sir. Sir, long back I have seen a patient of Lawrence-Moon-Biddle syndrome. It was having retinitis pigmentosa. People were, optic discs were oval. And syndactyly was there, polydactyly was there. It was 14 years old child.
Yes, sir. It can be associated with eye signs. It can be associated with skeletal malformations, pubertal issues, and obesity, of course.
Yes, penis was small.
Yes, sir. Very rare cases. And you don't have to do any genetic screening. You can just make the diagnosis on the basis of these criteria for Bardet-Biddle syndrome.
ये जो बाउंड्री और
So we had basically seen the data for what happens to GDM patients and the child being overweight, and they are at risk for being overweight at around 6 to 12 years of age in their adolescent age group. So they are at risk. And in fact, not only increased birth weight, but small for gestational age children also are at risk for IGT, insulin resistance, and being overweight at that time. And I think the best cohort was this Dutch famine study for these children.
So both ways, if children are overweight, as you're rightly saying, that they are, even at birth, they will become obese. Children tend to become obese. So they have to struggle harder right from the beginning. That's usually because the mother is not having the correct kind of nutrition. Maybe mother is overweight, having gestational diabetes, as Samir said. But also, which he very rightly pointed out, that children who are actually mothers who are undernourished, their fetuses get programmed to live in a undernourished kind of environment. when they are exposed after birth to the modern foods, they very quickly put on weight. So it is both a maternal overnutrition and undernutrition that causes, low or high birth weight babies, and both these categories get into more metabolic
Yes, sir.
problems.
Exactly.
So thank you, Samir, for the scintillating talk. So I request Professor Harihar Trivedi sir, Dr. Prabhakar Tiwari, Dr. Sanjay Gupta, Mithal sir, Samir, for the lighting of the lamp. I take the honor to invite Dr. Shefali Bansal madam and Dr. Diwan sir, Dr. Sanjay Diwan sir, for the lighting of the lamp. Please, sir.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यम्
So we are all waiting for, as Samit has rightly said, Amitabh Bachchan of our field, Dr. Professor Amrish Mittal sir. So he'll be talking about the top 5 tips for obesity management. So that is something which is very important. So I take the opportunity to invite Dr. Professor Amrish Mittal sir. The stage is yours, sir.
Good morning, everybody. It's a pleasure to be here, and would like to thank again Sachin and Samir, who managed to fit the calendar in a way that I could come to this city, which I really like, and meeting old friends like Dr. Manoria and others. It's a pleasure to be here. Thank you very much for all the kind words, but I have 2 talks today, okay? One is, you might feel is really simple. And what am I saying? All of you know what I'm going to say in the first talk. Because there's nothing big, it's common sense. The second talk is slightly complicated, so we'll try and sort of simplify it so that we get clear clinical messages. I think what people like Sachin and Samir are doing is quite remarkable. When I joined endocrinology in 1984 as a DM student, there was 1 or 2 students per year across the country in endocrinology. And from AIMS, this was the first batch, one me and one Dr. Prasanna Kumar from Bangalore. And it has come a long way, and my young colleagues have spread the message of endocrinology. The specialty has flowered and developed, and I am delighted that now it's in the top-ranked specialties in NEET. And the boys and girls we are getting now for PG in endocrinology are among the best and the brightest. So I think that's important. That's a recognition of the fact that endocrine disorders are so common. I mean, if you regard obesity as an endocrine disorder, and you're saying 16% children in 2006 were obese, maybe 25% are obese now, that means everybody has some endocrine issue. So the need is very much there, and I'm glad that people are showing interest in this area. We were talking about how obesity has changed, and the other way around also. I just saw the score, and Australia has bowled out for 113. Okay, so India has to make 115 to win. So it'll again probably be a 3-day match, very likely. But the reason I'm bringing this up is that when we were young and we saw the Bedis and Prasanna's bowl, they were highly skilled, but they were certainly not athletes. But when you see the Virat Kohlis and Jadejas and others now, there is a huge difference. They are fitter than, leaner than even their Western or Australian counterparts. So basically, if awareness is there and if the right approach is there, Indians actually, despite their overall soft bodies, can actually be very fit and fitter than anybody. So I think that's very, very important. You see the fielding nowadays and see the fielding in the 70s. It was very, very different. And so I think the message here is that it's not doable. It's very much doable. It's just a matter of getting our heads together. So the 5 tips for managing obesity is, the Samir put me in this spot. Which 5 tips should I use? I didn't know. So 5 tips. So anyway, so I've tried to choose some tips for managing obesity, and I was helped by someone who wrote on Medscape about 5 tips. So I chose those 5, but only the tips, but the rest of it is what I thought is important. So we still use BMI to classify obesity. There are many other ways. We know that waist-hip ratio is very important, and these are the Western BMI criteria. Why are Asian and Western criteria different? Because we start getting metabolic impact at a lower BMI. We have more percentage body fat at a lower BMI also. So it's not just the BMI, it's the proportion of fat that matters, and that too central fat. Right? So this is the classification. All of you know this. This won't show on white. So all of you know this classification very well. What is overweight? This is the classic textbook classification of how to call a person obese. But as I said, the waist-hip ratio and nowadays body composition done by routinely available machines are very important ways to look at it, not just BMI. A thin person may be unhealthier than a relatively overweight person. So that's important. But in Indians, of course, we know that there is a difference, not just Indians, South Asians in general. You start getting metabolic effects at BMI of 23. So ideally, our BMI should be below 23, which is actually very difficult. For most middle-aged Indians to maintain BMI below 23 is not easy. Okay? So 23 is our optimal BMI, and we start calling people obese above BMI of 25. So that is, I think, and we actually overweight is 21 to 23. So 23 to 25. So I think it's important that the BMI criteria are about 2 less in Indians as compared to Western Caucasian data, because their distribution of fat is totally different. This also is fallacious. There's oversimplification, but nevertheless, this is how we look at it at the moment. So important, when you read Western studies, make sure what criteria they have used, and our criteria are a little different. Now, you all know obesity's impact on health, and I'm not doing that. You know diabetes, you know hypertension, you know heart disease, you know arthritis, you know gallstones, and I think most of you also know cancer. There is a strong relationship between obesity and cancer. So higher circulating insulin, more growth factors, more chance of developing tumors. So there is a whole spectrum, and that's too sort of basic for you, and you're all aware. But sometimes, and I think Dr. Manoria mentioned that we forget the emotional impact of obesity, which is very important. It is not that fat people are happier people as we were told when we were children. Fat children, my mother used to like them a lot, and we were all skinny, so she was very unhappy. So and they were happier, they were supposedly, but that's a myth. Anyone can be happy, lean or fat, but in general, it's not a sweeping statement to make. In fact, with the current societal pressures, with the change in body image, people are struggling to become size 0 or whatever they call it, and lose more and more weight. So even some overweight can cause negative self-worth. Very important. Negative self-worth is, you see girls with PCO, their life is ruined because, they're only worried about their weight and their looks and whatever, natural. That leads to lack of motivation, anxiety, and severe depression also. Feeling of helplessness, people are trying everything. They actually are making a lot of effort, but they can't get there. They're self-conscious, and there is still a stigma. And that stigma, I'm sorry, does not limit itself to general society. It's also there amongst doctors. When doctors, see patients who are significantly overweight, obese, we always think, khata pita itna hai, ise kya bekar mein sab time waste kar raha hai hamara, it doesn't follow anything. But the truth is that is often incorrect. Often incorrect. So there is a deep-rooted stigma about obesity, which makes obesity very difficult to manage. And there has to be much more empathy, and I'll talk more about those things in this first talk rather than any very fancy science. So the tip 1, as far as I am concerned, is communication. Tip 1 for managing obesity is to connect with the patient. Connection and communication. You first have to be comfortable discussing weight. And there are two situations in this. One is, if the patient is worried about their weight, you have to make them comfortable that they come out with their worries and you discuss. Or if they are not, you have to make them aware. As Sachin said, some patient is just not aware that they are overweight. They think it's quite okay. Sugar doctor ke paas aaye, thyroid doctor ke paas, weight ka kya matlab? Weight se koi bimari to hai nahi. So they don't think of it like that, right? So it's both ways. If patient wants to discuss, you have to make them comfortable. And if you want to introduce very gently, you have to introduce the idea that weight may also be playing a role, So non-judgmental is the most important. We do not use the word obesity in our prescriptions anymore. We don't write obese, diabetics. Pehle standard likhe the obesity. We don't write that. Either we put an arrow and say increased weight or weight issues, but we don't write obesity. It's already a stigma, especially in children. So we don't use the word obesity at all in clinics. And this is not just us, but there are people who are now saying that we should not be using the word obesity. In doctors' meetings is all right, but not with the patient. So non-judgmental is very, very important. And the fact that we have to think of obesity as a chronic metabolic disease which needs chronic management. That is important. Now, I'm also against too much disease. Everything is disease. At least a condition, you can call it. It should not be labeled as nothing. But disease means everyone is diseased. So that's also, you have to be careful. But yes, it has to be labeled as a chronic medical condition which patient has to be made aware of, that it has to be tackled. Now, one very, very important point is to set goals for the patient. And one big challenge is that patient and physician goals should match. And this is, in my practice, that's a big challenge. The patient is looking at something else. When patient is keen to lose weight, they want to lose 25 kilograms. I'm happy with 5 kilogram weight loss at the moment. I'll say, let's lose 5 kilograms. Your sugars will improve, your metabolism will improve. They say, but I want to lose 25 kilograms. So other way around, as I said, patients may say that, we use these newer drugs. Patients say, oh, it's bahut duble hote ja rahe. 120 se 115 kilograms way, whole family is upset. Raunak chali gayi, charegi ekdam. So our goal should be clear. We should discuss, hamara first 3 months ka approximate goal itna hai. Let's try that. And set very conservative goals, not aggressive goals. So otherwise, we don't want to be like those rowers in the morning who we saw, both going in opposite directions, as you can see on the top right. Patient and physician have to move in the same direction. Our goals have to be similar, right? That explanation is very important. So therefore, now this is all very nice to talk about. The challenge is time. For all of us, that's a big challenge. So we need either to have counselors with us or we need to have a special obesity clinic. We need to give people time for that. We have to ask, we have to listen, we have to reflect, Is there a metabolic issue? Is there, and we have to empathize. I think empathizing is very, very important. If you tell somebody, for example, even with diabetes, कि मीठा खाओगे तो शुगर बढ़ेगी, and if you tell them, सभी का मन करता है यार मीठा खाने का, कभी कभी खाया करो, हफ्ते में एक बार खा लिया तो चल जाएगा. I agree that it's very difficult to give it up. You say that, you will connect immediately. You say, मीठा खाओगे तो यार क्या करेंगे, तुम्हारे लिए कुछ नहीं कर सकते, तो then the patient will sign off mentally. They'll not. And then what you want to do. So these are the steps you have to go through. And then you have to provide an overview of treatment choices. It's very important. I have been told when I've discussed everything, patient comes back after 3 months, you never told me about bariatric surgery. My uncle who lives in New York, they say everyone here undergoes bariatric surgery. मैंने कहा भाई एक ही बार मिले, अभी तो बात ही कर रहे थे डाइट और ये वो. तो choices mention करना जरूरी होता है. मैं तो prescription पे भी mention करता हूँ. Bariatric surgery discussed. So that at least it's somewhere in the patient sees it whenever, or when we see it next time, if patient is in that zone where he is a candidate, at least you say that we have to be aware of this. My job is to make the patient aware, then it's a patient choice. So diet, nutrition, exercise, there's no magic. We all know the steps for managing obesity. One is to just tell the patient, or patient says, accept ऐसे ही ठीक है हमारा weight, accept the weight where it is. Diet and exercise, we have to talk. Lifestyle changes overall. Medications for obesity should be introduced to the patient. We do have medicines. Maybe you don't want to try right now, but be aware that medicines are available. So mention, medication discussed. And this is the textbook Western slide to selecting treatment. And this is actually based on insurance policies and reimbursement. Okay, so they say that 25 to 27 with comorbidity, pharmacotherapy above 27 with comorbidity above 30. So this is a very conservative approach. Okay, so you can use pharmacotherapy for anyone who's overweight or obese if they are not achieving targets on diet and lifestyle. So, of course, you will always, doesn't mean that diet and lifestyle is the mainstay, will remain the mainstay. But if you're not achieving targets, but patient is not at BMI 30, then you can't say you're not BMI 30, so I won't give you medication. That is completely wrong now, in this day and age. That is just for starting therapy. For starting therapy, yes, you may say that, just immediately we start. But if someone is struggling and has already struggled, patients who come to us have often struggled a lot for years before they reach us and say that we have tried everything, nothing is working. And therefore, you just have to go on medical therapy then, drug therapy. So you have to weigh that, individualize it, and not just go by strict criteria that, drugs should only be offered to people who are above 30 BMI. ऐसे कुछ नहीं ज़रूरी है. Because after all, what are you doing with medication? We'll come to that. You're losing, in general, 4 to 5 kilograms. तो वो उतना BMI पे उससे बहुत ज़्यादा BMI change भी नहीं होगा. So what I'm saying is that balance it out. We have to individualize our approach to using medications. So then some people say, oh, I exercise a lot, which is very good. But exercise alone will not make you lose weight. It's very, very important. So while you have to encourage exercise, it has to be combined with dietary modification. You will not lose weight otherwise. Okay? Exercise alone will not make you lose weight. But it's very important to exercise while you're undergoing a weight loss program, because otherwise you lose a lot of muscle. When you lose weight, you lose a lot of muscle. So if you're not physically active, just doing a diet plan, you lose muscle. And when you've lost weight, to maintain it, you can't maintain it unless you're exercising. It's not possible. But per se, as a single approach to lose weight, exercise may not be the best. And many diets work. ये जो जितने आपको यूट्यूबर्स मिलते हैं ना, इनका एक्सपीरियंस होता है N of 1. जनरली अपने पे किया होता है, उनके लिए वो डाइट वर्क करती है, तो वही उनका साइंटिफिक एक्सपेरिमेंट है. यही सबके लिए वर्क करेगी दुनिया में. But the 30 years diabetes lean person with CAD and everything, वो तो डायबिटीज रिवर्स कर देंगे. कैसे रिवर्स करोगे? तो बॉडी मास इंडेक्स तो पहले ही 23-24 है बस, और 30 साल से नहीं कर देंगे डॉक्टर. वो कह रहे हैं कर देंगे. So ये, basically there is no magic in the diet. It's overall, you can follow, and I'll come to that, intermittent fasting if you like. You can, for short periods, follow keto diets if you like. you want to do even paleo diet, whichever diet you do, there is no magic. Ultimately, it is, I'll discuss what exactly it means. But basically, many diets will help patients. कोई एक single diet superior नहीं है. That's what. No one diet strategy appears to be superior. What are popular diet regimens? These days, intermittent fasting is the most important and most fashionable. We are not going into details of diet regimens. That's not the topic. But you know that the 16 hours and 8 hours, that is 16 hours of fasting with 8 hours of eating, is very important. It does work. Intermittent fasting is useful for some people who prefer it. Most studies have not shown a difference between overall calorie restriction, conventional versus intermittent fasting, but there is some evidence that maybe it is superior in some patients. So, and intermittent fasting is something that has been advocated from the time of Buddha and Mahavir, and so it is something that has been there in every, even in Islam, everywhere intermittent fasting in some form or the other is recommended, and in every religion recommends fasting in some form. And there is something there which may work for you. For some it is not possible, but for some it may be useful. So don't write it off. There are many things you can do, 2 days fast in a week, absolutely. But the most popular one is 16 hours fasting every day, 8 hours eating. But in 8 hours, then you have to be careful what you eat and not eat, as we said, samosas and kachoris all the time. So that won't work. You could do a ketogenic diet, which is so intermittent fasting is an eating pattern rather than constituents. Ketogenic diet is a high-fat diet, based on the fact that if you're giving very low carb and high fat, your fat will start burning down. So ketogenic diet is difficult. True ketogenic diets are very difficult to follow. Such low carbohydrate is not easy, and you should not follow them indefinitely. Maybe 2 months, 3 months. अगर properly करेंगे तो उससे ज़्यादा हल्का ketonemia रहता है, nausea. It's not that fantastic. Some people love it, but again, same thing. You go on YouTube, you'll get totally confused. Intermittent, they will say keto diets के अलावा कोई diet ही नहीं है दुनिया में. Okay. And then the paleo, of course, we'll not talk about today. But a number of dietary patterns can lead to weight loss. But basically, energy-dense foods have to be reduced, which means that if you have a whole bowl of salad versus one slice of a cake, the calories may be more in the cake. So energy-dense means कि जिसका size कम लेकिन density energy की बहुत ज़्यादा है. So you have to use things that will fill your stomach, right? And not provide calories. So you're able to achieve satiety without excess calories. That is the challenge. And of course, whether you should go on low this, low that, basically, by and large, most people agree, low carbohydrate diets should be there. Diets have to be low in refined carbohydrate. In Indian diets, fat is not such a big culprit. We are a carbohydrate society. And if we want to improve our health, then we have to use less refined carbohydrate. And on the picture on the right, it's a small picture, but I have put a picture of millets that are on display in this hotel itself. With the movement about millets happening, it is very much possible to move to other grains rather than highly processed wheat or polished rice. So at least mix it up, add those. But remember, if millets are also processed the same way as wheat is processed now, in 1 year, you will have so many commercial brands because the Prime Minister himself has pushed this very hard. They will be the same. The millets are important because they have fiber, because they have lower glycemic index. We polish them, process them, make it very easily digestible. Again, same thing will happen. So you have to look at those things. You have to look at higher fiber, lower refined carbohydrate. Very, very important. You leave this. In principles, our diet has to be low in refined carbohydrates, high in fiber. Moderate to high amount of protein. Protein, why? Protein is not just important for our bodybuilding, for our muscle, especially when we are taking less carbohydrate. It's also important for controlling blood glucose, for example. If you have more protein in your diet, you get less post-meal swing. So it's important to have adequate protein. Many people don't like being told these things, अरे हमारा तो हम हमेशा से ये खाते हैं, जनरेशन से हमारे घर में ये खाना होता है, आप तो ऐसी बात बता रहे हैं. But most Indian diets are protein deficient. Vegetarian Indian diets are specifically protein deficient, unless you are from Haryana, where you have so much of milk every day, for example. That's why you get all the athletes from there. Why do you get all the athletes from Haryana? Because they are stronger, because they have more milk, not because they have too much non-vegetarian food. So what I'm saying is protein is very, very important in our diet. And the mistake that science made was replacing fats with carbohydrate. Fat shaming started in the late 80s with the cholesterol hypothesis, and therefore people said fat ekdam kam karna hai, which is okay. But they replaced the fat with carbohydrate. The Americans did that, the whole world followed. And the epidemic of obesity and diabetes increased. Whereas fat has to be replaced with good fat. Fat is very important for body. So fats that have less saturated fat, more mono or polyunsaturated fat, olive oil, canola, so many, even mustard, soya, and nuts, badam, akhrot, no question about that. Fish. For fish eaters, it's a big thing. In Japan, their health is largely maintained because of the fish they eat. But they don't fry their fish. That's a big difference. Hum log fry, to phir sab wahi ho gaya. But what I'm saying is that these are the basic principles. We won't spend time on each constituent. We'll leave it like that. I think this is not required. And exercise, of course, again, we'll not spend too much time, except patients will ask, कौन सी exercise करें? तो आपको उल्टा पूछना है कि कौन सी आपको अच्छी लगती है? अगर आपको योग अच्छा लगता है, एरोबिक्स करो तो कहिए, तो अजीब बात कर रहे हैं. अगर आपको बैडमिंटन खेलना अच्छा लगता है, मैं बोलता नहीं, आपको तो लॉन्ग वॉक्स करने चाहिए, तो कहिए. तो जो आपको अच्छा लगे, do you want community exercise, do you want individual exercise, do you want you're a private kind of person, उसमें ही मॉडिफाई करना चाहिए. किसी को भी नई चीज बता दो, वो 2 दिन करेगा, उसके बाद छूट जाएगा. जो उसे अच्छा लगता हो, that is very important. That when you talk to the patient about exercise, ask them what they like to do and modify that. And इसमें थोड़ा ये भी ऐड कर लीजिए, थोड़ा ये कर लीजिए, एक दिन ये कर लीजिए, एक दिन वेट्स कर लीजिए, एक दिन और खाली योग नहीं करिए, और भी कुछ करिए साथ में. या योग में आप सूर्य नमस्कार बढ़ाइए अपने, whatever. So you have to do it like that. It's very important. Not कि सबको ये करना है, एक ही प्रोग्राम है. So sleep is important. I've just put this slide. You can forget leptin, ghrelin, but sleep is a very important contributor to obesity. Lack of sleep, in urban India at least. If you don't sleep well, you will get the wrong hormones circulating, and you will not be able to lose weight. A big challenge. Sleep and stress are 2 factors we don't talk about enough when it comes to weight and diabetes. We talk mainly about diet and exercise. We forget these 2. So sleep and stress are also very important lifestyle things. Stress, of course, this is the hardest one for me. Everything else I can talk to the patient, but I can't really relieve that stress. Everyone has their own stress. Doctors have their own stresses. So people have to find out the way. They may be given guidance by leaders, by gurus and others, but they have to find their own way for stress battling. So quite clearly, if you're constantly under stress, it is very difficult to lose weight. Very difficult to lose weight. Some people who are very anxious will lose a lot of weight because they don't eat at all. That's a different group. But for the usual mid-level stress, if you're stressed all the time, probably your cortisol level is high, one of the theories. But it's very difficult to lose weight. So that's an important factor in this thing. So, deep breathing, getting enough sleep, hobbies, leisure activities, जो सब ज्ञान देते ही हैं, वही ज्ञान देना होता है. पर पेशेंट को ही चूज करना पड़ेगा कि क्या मुझे सूट करेगा. What do I enjoy doing? Whether it's music, whether it is friends, whether सबका अलग अलग होता है. So you can't just say, and some of them may actually require support. So this is the best way of beating stress that Dr. Sachin follows, and he took us there in the morning. You have these scenes in the morning, then automatically your stress will melt away. And Bhopal is a blessed city with such beautiful areas and lakes and forests. So I think there's nothing better for someone like me. I find it very difficult to exercise alone at home. For me, these walks are really helpful. In Delhi, also we are blessed to have many parks and this thing. So very, very important to have that stress level coming down. But we must also talk about medications to the patient. We must suggest medications if they are indicated. But remember, the average weight loss is not like 20-30%. Patient sometimes expects that. American insurance to chodiye. But the last point is also important, which you have to very gently, maybe not tell at the first visit, but sooner or later patient will ask, how long will the medicine go on? So you have to say that the medicine will help you get a kick start, but basically you have to manage it yourself. So while the medicine helps you bring down your weight, then by that time you should be in good shape to be able to maintain it. Because when you stop the medicine, weight will go up. That's not rebound, but it'll come back to where it was. So I think this is important. We're not going into all the medicines. Samir is very rightly listed. We'll let them be medicine list. But we will, okay. And again, he mentioned that about children, but read the third point in this. This is also a Medscape slide. Only 1 to 2% of patients with obesity are prescribed a weight loss medication. So there is a gap at our end. And that gap is not our fault also, because obesity medications history is really bad. In the past, all the drugs that came for obesity had so many problems. But now we have drugs that came for diabetes and also help manage obesity, which is very different. So the safety is, now you're not worried about long-term safety. So I think that is important. That's why none of those drugs picked up. They're there, but they have not really picked up. This again is who can take. This is Western guideline, but anybody can take weight loss drugs if they're trying their best with diet and lifestyle and they're not achieving targets. Yes, if they come with a high BMI initially, you can even think of starting drugs along with diet and lifestyle, even initially. There's nothing wrong in that. Anyone who's not meeting targets with lifestyle. Now, if you look at semaglutide, oral semaglutide, okay, I will need something visible. How does one use a pointer? Actually, वो white है ना background. I used the wrong background. नहीं दिखाई पड़े. Very tiny. Okay. Anyway, so the blue bars are semaglutide. Okay, blue bars are semaglutide showing, yeah, much better. The blue bars are semaglutide showing the degree of weight loss. This shows the duration in various studies. So, okay, which is the best weight loss? Mean 5 kilograms. Right? So, drugs like semaglutide, we are talking of oral semaglutide. In my next talk, I will discuss the actions of GLP-1 in helping us lose weight. This is just to introduce the concept that, yes, these drugs help in weight loss, and oral semaglutide is very important in that because it's available to us now. We have injectable liraglutide also. At least these two are available, which can help in weight loss significantly. And here, if you see, this is comparison with other drugs. Don't have to go into all details. But the fact is that in different studies, depending on the population, you do lose weight with GLP-1 receptor agonists. I will describe the mechanism in my next talk. But yes, so there is an option for some weight loss at least. So oral semaglutide does help in weight loss, and it is sustained. If you continue the drug, the weight loss is sustained. Regardless of age, baseline body weight. If you have higher baseline body weight, you obviously lose a little bit more. Like that's true for everything. The challenge for us would be the background medication for people who treat diabetes, because some of the medicines we use can definitely cause some little weight gain, insulin per se, if you're using pioglitazone or something, even the sulfonylureas. So then the weight loss in diabetics with these agents is always little less than in non-diabetics. It has to be less, because there are other factors in diabetics which prevent weight loss. I think that's something we need to keep in mind. And the last tip is that we should discuss bariatric surgery. The patients react very adversely, violently sometimes to this suggestion. You just say, okay, first thing you tell them, I'm not a surgeon. Then they feel better. So I would also like you to be fixed without surgery, but keep that in mind. Don't shut your mind to it. That's all I do at the first time. You know, just keep it open. If we are struggling, not getting anywhere, we can consider surgery. Okay? Although many of them are ideal candidates for bariatric surgery at first visit itself. But they often, some may, but often they don't agree. You won't go into bariatric surgery guidelines. So your job is not to make patients lose weight. Your job is to have a conversation with patients and help them make informed choices so that they can then lose weight. That is very important. It has to be a two-way thing. It cannot be a prescription. Weight loss ke liye koi prescription akele kaam nahi kar sakta. Then you will, as I said, you have to empathize with people, and there should be no subconscious blaming too. That's very important. So the 5 tips are communication, provide overview of treatments, discuss lifestyle, discuss drug therapy, and bariatric surgery. Thank you very much. Thank you.
The house is open for questions.
Yes. So empagliflozin does result in weight loss. We've all seen that. At the moment, it's not approved for that indication. So we are not, to be honest, we are not using SGLT2 for weight loss alone, but we are using GLP-1 for weight loss alone. But yes, it has definitely helped diabetics lose weight, and maybe at some point it will be used in non-diabetics also. Yes, yes.
And is any role of biomarker like irisin, serum biomarker like irisin in the diagnosis of obesity?
So yes, there are several serum markers that have been used obesity, and including the good old leptin and leptin resistance and ghrelin and others. But I don't think that will make much of a difference in our clinical management. Clinical management is based on these clinical criteria only. What is the current weight, current BMI, what are the comorbidities? That's how we decide how aggressive to be. But everyone should try to be optimum body weight. So that's a very broad sort of guideline. Sarcopenic obesity, of course, is a big challenge in India. And what Samir was saying, that bone density in overweight adults is high, not always. Now new data is coming that bone density might be high, but fracture rates are higher in obese adults because they have low muscle mass. So in India, we can have both together. Everywhere we can have, but more in Indians, where we have people who are overweight, but their muscle mass is really low. So it's a double hit. Insulin resistance will go up many-fold. So there is no doubt that we have lower muscle mass. You can be obese, but you can still have low muscle mass.
So is there any relationship between gut biome
Yes.
and obesity?
That's a huge and very interesting area. I think there definitely is a relationship, and I think our ancient wisdom also suggests there's a lot of relationship of gut but it's not been translated into direct clinical benefits yet. But there are lots of studies going on. हम लोग probiotic एक lump sum एक probiotic के कर देते हैं, but there's a lot more nuancing there which is required, and there may be agents that if you improve gut health, you can probably improve obesity. But that is a very broad statement. You will agree. How to improve it and what exactly can we do is not yet clear.
Sir, any role of metformin in non-diabetic obese person?
Yeah. So metformin is used in non-diabetic situations. It's used in polycystic ovarian disease because it improves insulin resistance, increases ovulation chances. The weight loss with metformin is not that much. That is the problem. That's why it never got approval as a weight loss agent. So the amount of weight loss is not great. And some patients, also may have lost a lot of weight is because they are doing diet, lifestyle. And there is a small segment of people who lose a lot of weight with metformin. And they just actually shrink. That's small. So metformin can be used. It's a safe drug. There's nothing really wrong. But it doesn't work that well.
So-called specialists about diabetes and all these things, they have been promoting the fructose. What is your take about fructose? Because the normal sugars, they contain 50% of fructose. The sucrose is made up of fructose and glucose. The molecule is complex molecule. And the fruits also contain fructose. So they say that take this fruit and fruit diet and this diet and that diet. Fruits, I think, contains fructose because fruit name comes from fructose.
Yeah. So I think it's important.
Obesity and fructose.
Yeah. So I think it's important to realize that fructose can cause problems. Fructose can cause insulin resistance. It can increase even NAFLD. So I think everything has to be in moderation. So let's say for diabetes, when we talk fruits and diabetes is a common question, right? So we say you can have 30 grams of carbohydrates through your fruits every day. and in 2 servings of 15 grams each. If you're not diabetic, of course, you can be much more liberal. But presuming that because you're taking fructose, you will have better outcomes than it's not proven, not in a clinical setting. People are saying, you're right, but I don't think that. Well, if you're going to have only fruits, where will your protein come from? Diet has to be balanced, you know, and sometimes you just follow these diets without going into the analogy, but I don't think fructose in that sense will be healthier. Yeah, okay, thank you.
Thank you, sir. You have enlightened us with the 5 tips of obesity management. Thank you. Thanks a lot. Now it's the time to go ahead with the GLP based topic. Again, sir has nicely sensitized us. So I invite Dr. Sameer Agrawal. He'll be talking about GLP-1 in diabetes care, who, when, why and how. Professor Dr. Sameer Agrawal.
Very nice presentation by Dr. Mittal, sir. I think he has elucidated some practical tips, and the audience questions were really, I think, encouraging. Microbia and obesity, I think still the confusions are there. We do not have clear-cut, as told by Dr. Mittal, sir, correctly, no clear-cut role of these microbia, and maybe some inflammation is going on. So we are still not clear what's happening in the gut and the obesity part. So talking about obesity, so we need therapies in management of type 2 diabetes, which in addition to glycemic control leads on to weight loss, or maybe they are weight neutral, but it would always be encouraging if we have therapies which can cause weight loss. We have been going through this famous octet for pathogenesis of type 2 diabetes, and the scientists world over have been trying to come for therapies and discovering therapies which can target these various pathophysiologies of type 2 diabetes. Metformin is one of the drugs which takes care for your glucose levels, and it takes care for the weight also. Then I think we had SGLT2 inhibitors many years back, which is again taking care for your glucose levels and also causing weight loss. So, but we have seen sometimes this weight loss is not an ongoing phenomena. On an average, we know that SGLT2 inhibitors lead on to somewhere around 60 gram of glucose loss in the urine, and this effect sometimes gets blunted after a few months of use. So we will be, I will be throwing some cases. I have taken some cases from Medscape, and I've tried to incorporate some data from my side, and we'll try to see what the literature says about GLP agonist in management of type 2 diabetes, which patients groups should be subjected to GLP agonist, why we should put patients on GLP agonist, when and how. So we'll be touching on those aspects of GLP agonist. We know that there are 2 glucagon-like peptides, and there is a blunting of incretin effect. So you have 2 ways to take care of blood glucose control. Either you give a GLP which is not being degraded, or you give a DPP-4 inhibitor. DPP-4 inhibitor will lead on to some decrease in HbA1c, but it's weight neutral, whereas GLP agonist like liraglutide, dulaglutide will take care of blood glucose levels and will also take care for the weight part. There is another peptide called GIP. I think it has been under shadow of GLP since years. And now we have been targeting GIP and GLP agonist with drugs like tirzepatide, which has been approved in US, I think last year, for management of type 2 diabetes. So how do these GLP agonists work? You all know that GLP agonists stimulate insulin secretion from the pancreatic beta cells, and simultaneously they decrease glucagon secretion from the alpha cells of the pancreas. Other mechanisms like decrease of the gastric emptying, acting at hypothalamus level to improve satiety, decreased food intake are some of the other effects in addition to weight loss. So they increase the cyclic AMP, that's what we understand broadly, and how this is how they stimulate the insulin secretion from the beta cells. We had injectable GLP agonists since long, like liraglutide or dulaglutide, but now we have come up with oral GLP agonist also. They can be used in type 2 diabetic, and I think you can use it at any stage of type 2 diabetes. And post 2008, I think FDA requires that any new anti-diabetic drug which is being launched into the market must prove that it is cardiovascular safe. So this is a case, 55-year-old on metformin, 2 grams per day on empagliflozin, and the patient had previous myocardial infarction also. So patient of type 2 diabetes and CAD, and patient's priorities. I think we must discuss and individualize our treatment, that what the patient wants from us. He wants to lose weight and to avoid any hypoglycemias. And if we see the BMI, the patient falls into obese category. Of course, this patient is from the area where Dr. Mittal works, not from my sort of area. My patients have the usual suggestion that I just want a glycemic control. That's all. I think many people will have this concern that they just want glycemic control. But this is a literate patient. He wants to avoid hypoglycemia and want to use a drug which can be cardioprotective and maybe renal protective. In fact, I think this should be the perspective from our point of view also, to use a drug in management of type 2 diabetes which is cardioprotective and which has good effects on renal outcomes also. Patient's HbA1c is high, fasting and postprandial both out of range, and patient also has slightly increased LDL and slightly increased albumin-creatinine ratio. So this is what ADA EASD guidelines suggested way back in 2019, that if the patient, seeing the cardiovascular outcome trials of various drugs and GLP agonists, they suggested that if the patient is having established ASCVD, then after metformin and lifestyle, you must select a drug which is safe for the heart. So independent of baseline or target HbA1c, we must use a GLP agonist or an SGLT2 inhibitor if the patient is having underlying ASCVD, as is present in this case. If the patient doesn't have, I think many patients in your routine OPDs will not have underlying ASCVD or will not be at risk for adverse cardiovascular outcomes. Maybe you can select a sulfonylurea or a thiazolidine or a DPP-4, any other oral hypoglycemic drugs. So any change in 2022 from ADA EASD? I think this suggests that if the patient is having underlying ASCVD independent of the baseline drug therapy or HbA1c, there is a strong recommendation from EASD and ADA recently that you must select GLP agonist or an SGLT2 inhibitor independent of background use of metformin or independent of baseline HbA1c. So I think in this case, where the patient is already on metformin, patient is already on empagliflozin, I think if the patient concern is for glycemic control and weight loss, then a GLP agonist, whether it is oral semaglutide, liraglutide or dulaglutide, you can select any of these. And you can discuss with the patient what he wants. A person with type 2 diabetes and obesity, another 42-year-old male, BMI 33, again fasting and postprandial not controlled, HbA1c around 9.2%. And the patient is already having hypertension, dyslipidemia, and some comorbidities which can be there associated with obesity like sleep apnea. And patient's drug treatment, if you see, patient is on 2 gram per day of metformin, 4 milligram per day of sulfonylurea, empagliflozin 25 milligram, and sitagliptin 100 milligram once in a day. So patient is practically on most of the therapies which we use in our clinics in day-to-day practice. Also, of course, patient is on atorvastatin, lisinopril, and diuretics also. So very poor control despite 4 oral agents. And the patient is on polypharmacy, and patient is obese and is having complications related to obesity also. Again, if we see the 2018 way back guidelines, they had suggested that if the issue is of weight, then you must select a therapy like SGLT2 inhibitor or GLP agonist. And this patient, since is already on SGLT2 inhibitor, DPP4 inhibitor, metformin and sulfonylurea, I think we can't do beyond that. But one thing is very important, that once you are seeing a type 2 diabetic patient with poor glycemic control and multiple drugs, just rule out that the patient is not suffering from hypoglycemias. Just ask the history, and maybe it would be a good idea to see what happens to the log of the patient. Sometimes, instead of increasing the therapies, if you cut down on sulfonylureas, that can help you. That will not only remove the hypoglycemia, that will also cause some weight loss. But there was no such documented hypoglycemia in this patient. And in fact, again, the ADA ESD guidelines strongly suggest that if you have a concern for weight, if you see this, the rightest part there, if you want to select a therapy for weight loss, this patient is already on empagliflozin, then you can select a GLP analog which is having a very high efficacy for weight loss. We do not have injectable semaglutide at the moment. Oral semaglutide can be used, or even you can use dulaglutide once in a week. Already patient is on 4 drugs. Maybe he is not comfortable with another daily injection, and you can select a therapy which can cause a weight loss. In fact, if we see the data where GLP agonists were already added to baseline therapy consisting of SGLT2 inhibitor, you see more weight loss, these light green, where exenatide weekly plus DAPA, both HbA1c and weight change was significant. In fact, we had data from SUSTAIN 9 also for semaglutide in type 2 diabetes inadequately controlled by SGLT2 inhibitors. You had both HbA1c and significant weight loss. About 10 with dulaglutide 1.5 milligram once in a week also showed that when you add dulaglutide to underlying therapy consisting of SGLT2 inhibitor, you see a weight loss with both 0.75 as well as 1.5 milligram of dulaglutide. So, in fact, if we see the weight loss with SGLT2 inhibitors and with GLP agonist like semaglutide, I think this was a good study, Pioneer 2 trial, where the weight loss which happened with empagliflozin sort of stopped, patients stopped losing weight in this trial after 26 weeks, whereas the weight loss was ongoing till 52 weeks with oral semaglutide. I think this is a significant study and showing a significant difference with regards to ongoing weight loss with GLP agonist like semaglutide. So in this case, this is the case second case which I am discussing. That patient is already on these 4 drugs, and you have taken a decision to start, let's say, dulaglutide weekly, either 0.75 or 1.5. So what change you should do? Important thing to remember is that you should stop a sitagliptin, because you cannot give a DPP4 inhibitor and a GLP agonist at the same time. This is what it was done. Dulaglutide 0.75 milligram once a week was started for a couple of weeks, and then patient tolerated this therapy well and was put on 1.5 milligram once in a week. After around 3 months, there was weight loss of around 3 kg. Sometimes you can have more weight loss. We have seen weight loss of around 6 to 7 kg also, and this trials also have shown that weight loss can occur up to 3 to 6 kg, but sometimes clinically we have seen weight loss up to 10 to 15 kg also with GLP agonists. And fasting as well as postprandial glucose went down and HbA1c touched to around 7.4%. So I think whenever we are selecting therapies in management of type 2 diabetes, it becomes important to select those therapies which cause HbA1c reduction as well as which can cause weight reduction. Another case with diabetes, impaired kidney functions and features of hypoglycemia on blood glucose monitoring. Patient had hypertension, dyslipidemia. Patient is on metformin, 2 gram per day, and sitagliptin, 100 milligram, plus high doses of glargine, 44 units once in a day. So 3 drugs for management of type 2 diabetes, and seems to be on quite maximal doses of all of these drugs. Interestingly, albumin-creatinine ratio was normal, but GFR was decreased. So you have sometimes these cases of diabetes and CKD where you have a low GFR. So I think it's important to check for GFRs also in diabetic patients and just do not rely on albumin-creatinine ratios. So patient was having poor glycemic control on 3 drugs, 2 oral and almost high doses, maximal doses of, you can say, glargine, and some hypoglycemias and decrease in kidney functions are there. So goals are to improve the glycemic control and reduce the risk for cardiovascular disease. And we have seen the CKD progression occurs in type 2 diabetes from UKPDS data. Nephropathy, no nephropathy still progresses, and micro and macroalbuminuria progresses at a faster rate. So options in this case we can discuss is, we can add a sulfonylurea, we can add pioglitazone, SGLT2 inhibitor, GLP agonist, or we can start a basal bolus therapy. So we have seen that glucose control with SGLT2 inhibitors, when they are added on to insulin regimens, there is a decrease in HbA1c. In fact, with GLP agonist also, interestingly, we had this data where exenatide was added to baseline therapy of glargine, and it was compared to sort of basal bolus therapy of Lispro 3 times a day. In fact, we have very few data which have compared GLP agonist versus a prandial insulin. In fact, it was flat sugar study by Rosen et al., where they had shown that exenatide added had similar glycemic control versus 3 times per day of a prandial insulin. Another once in a week albiglutide also showed the similar results. A GLP agonist added on to underlying glargine, and the similar glycemic controls were there. In fact, IDEC-LIRA versus basal bolus insulin therapy has also been studied, and it has also shown comparative results where it was compared to 3 times of aspart added on to underlying basal insulin therapy. Award studies also showed good results with dulaglutide once in a week when it was added to glargine, particularly in Award 9 studies that helped in good glycemic control, weight loss, and cutting down on the doses of underlying glargine, particularly in Award 9 studies. So, in fact, the ADA guidelines also suggest that if you have a patient of type 2 diabetes, CKD with albuminuria, then preferably SGLT2 inhibitors can be put on the board. But if you have a patient of type 2 diabetes, CKD with normal albuminuria, but low GFR, then GLP agonist or SGLT2 inhibitors, any of these can be started. But we know that if I want to decrease HbA1c and take care for kidneys, both at the same time, SGLT2 inhibitors will have a blunting of effect with regards to HbA1c reduction once the GFR drops down. So this patient was initiated on GLP agonist, and we had good glycemic control and weight loss at around 3 months follow-up. So we should consider GLP agonist in management of type 2 diabetes, since we have good data which has shown that HbA1c reduction, and we have CV outcome trials also with many of the GLP agonists which we are using, like liraglutide and dulaglutide. The HbA1c reduction efficacy has been shown from various trials of GLP agonist. The weight reduction, I think, is a thing which is very important with GLP agonist. The issues of GLP agonists sometimes can be GI side effects. I think it has to be clearly communicated with the patient before you start a GLP agonist. So GLP agonist can be used with most of the underlying therapies, whether it is metformin, sulfonylureas, pioglitazone, or it can be combined with even basal insulin. So once the type 2 diabetic patients, they are not being controlled on cocktail of therapies, patient is overweight or obese, and we want to select a therapy which can promote weight loss, which is cardioprotective, I think GLP agonist fits into all of these properties. So individualization of goals is important. What the patient wants from his type 2 diabetic therapy is important. If the patient is having underlying ASCVD or risk factors for kidney disease progression, I think SGLT2 inhibitors and GLP agonists both have a significant role in management of type 2 diabetes. And after metformin, I think these are the drugs which can be introduced quite early on. So these are the GLP agonists available, like liraglutide, oral semaglutide, and dulaglutide in India at the moment. The GI side effects can be decreased by judiciously selecting the doses. Like liraglutide, we can start with 0.6 milligram and then build up the doses. With oral semaglutide, you can start with 3 milligram for a week, for a month, and then you can go to 7 milligram or 14 milligram. And sometimes you can cut down on the underlying doses of metformin also to decrease the GI side effects. Do not start these drugs if patients have history of gastroparesis and any underlying history suggestive of pancreatitis or medullary thyroid carcinoma. I think properly, if you have selected your patient and build up on the doses, that can decrease the side effects with these drugs. So counseling is important, and patient has to be told that yes, you can have this nausea and vomiting for initial couple of days or weeks, and you can use drugs like ondansetron to manage that initial nausea and vomiting. So dose escalation strategies should be, I think, taken into account. So GLP-based therapies provide good HbA1c control. They cause weight loss. They have pleiotropic benefits in addition to HbA1c control. I think Dr. Mittal will be talking on non-diabetic uses for this group of drugs. Side effects which can happen with your patients, so you have to be alert, patient has to be alert, and you have to tell in advance before starting a GLP agonist. If the patients complain of nausea and vomiting, listen to them, because sometimes it can be a pancreatitis which happens and you miss it at initial nausea and vomiting. So it's not a bad idea to do a amylase or lipase ultrasound pancreas. So be sure from that point of view, and be in touch and communicate with your patient that if you have nausea and vomiting or pain abdomen, then what he has to do. These drugs, in addition to HbA1c, weight loss, they have other cardiovascular benefits, as has been shown in the REWIND trial, in the LEADER trial, and the SUSTAIN 6 trial. And now we have the oral GLP agonist, which is also available. So educate and explain the patient, escalation of the doses, and effective management of GI side effects is required whenever you are initiating a patient on GLP agonist. Thank you all.
Thank you, Samir, for an elaborate lecture on how to initiate GLP analog in our clinical practice when you're dealing with a case of diabetes. That is quite a burning topic. In your clinical practice, you must be encountering this symptoms of constant GI symptoms. So, what is your take on this? How should we start?
So usually, like for oral semaglutide, like I told, we start with 3 milligram and then go up to 7 milligram after a month. With dulaglutide, we start with 0.75 once a week, wait for a couple of weeks, and then you can increase to 1.5. And same way with liraglutide, we start with 0.6 milligram and then go up to 1.2 milligram.
Especially with oral semaglutide, there was again a drop in the patients, number of patients who were taking semaglutide. Initially, there was good number of my friends who used to say, "यार इस दवा को लिखोगे तो patient भाग जाएगा." So, what is your experience regarding this? Now, because now I've learned, but initially to start with, and what about using this drug with, because there are good number of my patients who are on thyroid therapy also. They are on levothyroxine supplementation. आप बोल रहे हो कि it has to be given on empty stomach. What is your take on this?
So, we have been putting this drug, oral semaglutide or Rybelsus, since many months now. And I think the dosing instructions are a little bit strict. You have to take in this drug in the morning, empty stomach with 250 ml of water, and you don't have to take anything by next 30 minutes. So that's a little bit strict instructions. Otherwise, patients, I think, are always comfortable with any oral therapy as compared to injectable. Thyroxine absorption can increase. I think this has happened more with 14 milligram doses of Rybelsus. So I think if you see a patient of hypothyroidism and diabetes, and you see a TSH falling down, maybe you can cut down on the doses of thyroxine on follow. But I think you have to be alert whenever you have semaglutide oral and thyroxine.
If someone is on liraglutide, suppose to say he is on 1.8 milligram of liraglutide, now he wants the oral therapy. What should be your regime? Immediately you will switch over to 14 milligram, or you will go stepwise escalation?
You can switch over to 7 and 14, any of these doses, I think, straight away.
But this is what we see sometimes. I came across. There are good number of patients. There is not one-to-one switchover kind of regime for this. Ideally, this oral semaglutide, it wants to, that kind of build-up needs to be gradual. Every 10 days you need to
go. So if you are starting in a naive patient, de novo patient who has not been exposed to GLP, then you can start with 3 milligram. Start with 3 milligram, hold for a month, and then you can increase to 7 milligram. And if you still feel that he's not responding to 7 milligram for a month, or your HbA1c is not hitting, then maybe you can increase to 14 milligram.
How much?
Usually do not go beyond 7 milligram, and same with Victoza, not going beyond 1.2.
Can we go for 7 and 14 alternate?
I don't think.
Because there are a good number of people who prescribe like this also. Because sometimes the patient are tolerating 7 and 14 alternately, but they are not tolerating 14 milligram daily.
So I feel if the patient is not tolerating, he's not going to tolerate 7 also. So this has happened for a couple of patients. So, but I think more real world data will be throwing light on these aspects also.
How much of weight loss have you seen with semaglutide and the kind of HbA1c control and weight loss? What is your experience regarding the insulin dose?
So we have been able to cut down on the dose. If I talk about GLP analogs in general, we have been able to cut down on the doses of insulin. Many patients who were on basal bolus therapy, we have been able to do them good on even twice a day of premix. And I think we have been able to have a weight loss of around 5 to 7 kg in most of the patients.
What about injectable when they are supposed to be given? Is there any role of some kind of supplementation with food, or that is not important?
I don't think.
Previously, they used to say some grape juice can help, or especially with the GI symptoms and all.
I think each one has its own ways to manage it. I usually give ondansetron for a couple of days. That's how I go about it.
Which is your preferred GLP in your clinical practice?
I think dulaglutide 1.5 or 0.75 weekly, it's quite comfortable for the patient just injecting once in a week. So,
suppose they don't want an injection?
Pardon?
So if they don't want an injection, how do you equate semaglutide with dulaglutide?
So I think the HbA1c reduction of 14 milligram as compared to 1.5, we have very few head-to-head trial comparing oral semaglutide with dulaglutide, and they have compared with 0.75 milligram per week, not with 1.5 milligram per week. But the 14 milligram has shown better HbA1c reduction.
Now the good thing is it has been approved for obesity also, the oral semaglutide. Last week only it got approval with high risk. If there is the multiple comorbidities, you can give it as a drug for obesity also. So that is something as an add-on for oral semaglutide. So, and from the house?
Yeah,
Yes, sir. Dr. Manish Jain, sir.
Yeah, being gastroenterologist, I am always concerned about possibility of pancreatitis with GLP-1 and DPP-4 inhibitors both. So, what is your experience with are there any increased incidence of pancreatitis with these medications?
So rarely seen pancreatitis with GLP agonists. Yes, there has been cases, but practically in our clinic use, we have rarely seen.
Okay, one more thing. Before prescribing GLP-1 agonist, how to screen for MEN1 and MTC, what they theoretically recommend? This is a contraindication for prescription of these medications.
So no clear-cut statements on this, but yes, if the patient is having a thyroid nodule, you can just check serum calcitonin levels. So if it's normal, then practically this is ruled out. But we are not doing calcitonin practically before starting a GLP in our clinic patients. So
if there is a family history, if there is again the high chances of patient having this polyendocrinology,
so
especially
parafollicular C cells, they express very little GLP receptors. So this issue I do not think is of much significance with humans. Yes, sir.
In case of now practicality is there, it's a costly drug.
Yes, sir.
And especially in India, perspective is very difficult to convince the patient to take such drugs. So have you any experience of increasing a double dose of SGLT inhibitors in case of those who are avoiding these drugs or insulin?
So we do not go beyond the recommended doses, sir, for SGLT2 inhibitors.
So there is a story. They have checked this, especially with dapagliflozin. 10 milligram was the maximum dose. In their cohort, they went up to 300 milligram, 500 milligrams also. When the initial dose defining studies, phase 2. But they could not find, after increasing the dose beyond 10 milligram, there was no benefit with respect to glycemic control and weight loss. So it is more or less, it's like a polypharmacy, which we do with, especially with glimepiride when we give 8 milligrams or 16 milligram. I'm seeing patients who have been prescribed with 16 milligram. That is not going to help you because the first dose effect goes. Majorly the maximum dose is just because that is set, because that is the first dose effect. The moment that first dose effect is gone, you can increase the milligram of the drug, but it is not going to benefit in terms of the value we want for the drug to be given. So that is very clear for dapagliflozin. So double dose of sitagliptin, SGLT2 inhibitor will not help.
And one more question regarding beta cell enhancement. Reversing that or increasing, because generally we say diabetes occurs because 50% cells are already gone. So in case of this, what happens?
So there were animal data which has shown that GLP agonists are beta cell protective with regards to new generation of beta cells, but still till date it has not been replicated in humans. So that's the data till date we have with regards to beta cells.
Correctly, a patient was mentioned which was giving polytherapy 4 drugs including sulfonylurea, and at that time probably even after 4 drugs HbA1c was 8 or 8.9, yes, something like that. Now this is the classical scenario for insulin therapy, if I am right. Now in spite of that, this has been a preference that we have gone for this thing just for the little weight reduction property. So don't you think that seeing the legacy effect of insulin, a patient who is on secondary failure with sulfonylurea already, because probably the dose of glimepiride was 8 milligram.
4 milligram.
4 milligram.
Yes, sir.
So if you withdraw glimepiride, and to continue with basal bolus along with maybe metformin or SGLT2 inhibitor, what is the scenario in
So
that
this
case?
patient was already on SGLT2, patient was already on metformin?
No, agreed. But
Yes.
where do basal bolus regime stands in this kind of situation? So this concept shows that probably this has replaced insulin therapy.
Yes.
Because if a patient who is on polytherapy, 4 oral drugs,
Yes, sir.
including sulfonylurea, and if you want legacy effect for insulin to come, because
So
we
that-
know pretty well if you start insulin early, it is going to give you 10-year benefit later on, and there is no doubt about that.
Yes, sir.
So you mean to say that this is not the indication for insulin?
No, you are right, sir. We can always give basal bolus. That seems to be the most ideal regimen, where you give 3 times of prandial insulin and once a basal insulin, which is already on. But seeing this data where we have compared Lispro and Aspart with a GLP analog, GLP analog which was shown with exenatide weekly and with albiglutide weekly, they performed fairly well with regards to HbA1c reduction when you were giving Aspart 3 times a day or you were giving Lispro 3 times a day. And also in this IDEC-LERA study where it was compared to this prandial insulin. So the question is whether the patients are going to be compliant with 4 times per day of insulin per day, and the data which is showing that GLP agonist, longer acting GLP agonist are performing quite close to that prandial insulin. And not only you have a good HbA1c reduction, simultaneously you are having a weight loss. That I think is one of the edges with this. But yes, sometimes even after starting GLP agonist, if the patients are not responding, we have to go to a prandial insulin and a basal insulin, that is the basal bolus therapy.
Apart
so this
from
is not
that,
that once we have started a GLP agonist and we are waiting for years for glucose levels to come down. If we feel that after a couple of months the glucose profile is not hitting at the target, best is to again start a basal bolus therapy only.
The benefit is cardiovascular and renal benefits. So the GLP analog
The legacy
itself.
effect, earlier you start insulin, better you are.
Yes.
Isn't so if we are still waiting
So
for
the
one
legacy
more drug
effect
to come,
was for intensive control and not for insulin. It was for the intensive, even in the UK
DCC
study,
post-study,
the legacy effect was seen for those patients who had been subjected to intensive control, and that too in newly onset type 2 diabetes. This legacy effect was not because of insulin. It was with the intensive arm.
It was a matter of keeping the HbA1c as low as possible, sir. By whatever means you do it, that is the legacy effect.
HbA1c.
Yes.
So when we are going to start insulin then?
Patient
it
is-
seems that insulin has been replaced by GLP-1 agonist.
So this patient was already on a
Seeing to the
basal insulin.
comorbidities, he had obesity, he had a high risk of atherosclerotic cardiovascular disease, he had some little bit more risk of renal involvement. Why not? Let's have a molecule which will prevent this. Sir, what is your take on this, sir?
I think, sir, the legacy effect is largely for newly diagnosed diabetics, whether with or without insulin. So that's not a concern. Quite clearly, insulin is a very good choice in this patient. It would obviously be considered. But it is true that given the current understanding, if you can actually help them with other parameters, especially weight and reducing the risk of renal disease, there is nothing wrong in using GLP-1 RA at this stage instead of insulin. We were all taught, you and me, that insulin is the final answer, but there is a definite shift in that. If we are controlling glucose well, with protection, better protection to other organs, even without insulin, we can go on with multiple drugs for much longer periods. It's not replacing insulin. Nothing can replace insulin. If beta cell is totally gone, you'll have to use insulin anyway. There's no choice. But yes, you can, in many patients, avoid basal bolus by using a GLP-1 plus basal. There are many patients where you can, who have other parameters, lean patient, losing weight, there's no discussion. Multiple drugs already, patient trying everything, notice. But you know that the patient is overweight, you know that the patient is not very compliant with lifestyle, add a GLP-1 and you'll get very good benefits. With insulin, you will go on increasing weight, and you know, it sometimes can be counterproductive also. So there is a better choice now. Insulin retains its position, but there is a better choice, and many patients may not be put on insulin as early as they were earlier. That is the practical part.
And you will be saving on like 21 shots of a prandial insulin versus once in a week.
Sir. नहीं है मेरे पास.
Dr. Mittal,
Sir, rebound weight gain concept has not come up.
Stop it. If you're using it, and the patient is not as rigid or as strict with the lifestyle measures, when you stop semaglutide, weight will come back.
Included in almost all the regimes, then liraglutide came, and then semaglutide, which is the oral GLP-1 analogs. My problem, I'm a nephrologist, and my problem is to control blood sugar in those patients who have low GFR. And looking at the cost of GLP-1 analogs, I think that enthusiasm has died out, because the less costlier products are nowadays available. They are oral products, and especially I'm talking about leafloses. Because lots of studies like DAPA-CKD and DAPA-HF and etc., which cover almost all the comorbidities which are present in a diabetic patient, right? From SCVD to heart failure to CKD progression, etc., etc. So, and not only this, the GLP-1 analogs cannot be given in those patients who have reducing GFR or who have progressive renal disease, because the side effects are pronounced in those patients. But you can give these SGLT2 inhibitors in those patients. Even the latest study, which is the EMPA-CKD, has used it in just 20 ml per minute GFR. So even in the lowest of the GFR, you can use SGLT2 inhibitors.
But it will not be effective with regards to glucose reduction.
The glycemic benefits will go.
I think yes, glycemic reduction will go, but the other benefits, the pleiotropic
Yes,
benefits
sir.
like
Fully
heart
agree,
failure
sir.
and the progression of CKD.
That was also shown in the REVIVE trial as well as in the later trial with liraglutide with regards to doubling of serum creatinine, progression of microalbuminuria.
I think microalbuminuria was more targeted.
The three things was definitely shown, which we call it as composite renal outcomes in the later trial as well as in the REVIVE trial of the liraglutide. Doubling of serum creatinine,
Yes.
progression from normal to macroalbuminuria, and onset of end-stage renal replacement therapy. You will not be able to take care of HbA1c once your GFR is dropping down to around 40, 30 or 20. The award 7 clearly showed better HbA1c reduction with dulaglutide and also decreased progression of nephropathy.
So I think the point you're making is very valid. Half the point I agree with, which is that SGLT2 inhibitors are fantastic, and they've changed the way we treat diabetes. There's no question. And GLP-1 will have a tough time competing with them simply because of cost and inconvenience. Right? If you look at the
side effects also, as you talked about the tolerability of the things, the acceptability to the patient. The side effects are pronounced with the declining GFR.
Well, not that much. Actually, I'm using a fair bit of GLP-1 in patients with CKD, because some of them have very low insulin requirement, and they really, as you know very well, they almost require nothing. Some of them were obese, and CKD can actually require a lot of insulin. You can't use many quantities, only specific DAPA or EMPA, and there you actually have found them to be exceedingly useful. So I think GLP-1 analogs and SGLT2 inhibitors will not compete with each other. I think they will be complementary to each other. And I do think that there's no question that the field of diabetic kidney disease has changed after SGLT2. There is no doubt about that. But the fact that these drugs continue to exert their glycemic effect, sometimes in those kind of patients where insulin dosage are diabetes is not
there is a lability of blood sugar, because lability is a problem in kidney disease.
Yes, very true.
Sometimes the sugars, there's lots of episodes of hypoglycemia, sometimes sugars are soaring up.
Which is why this GLP-1 actually is very, very
In fact, you can use it at low GFRs for HbA1c reduction. Dulaglutide and liraglutide both.
We're using it actually.
Yes.
See, we do not want that much of HbA1c reduction in those patients who are in advanced kidney failure. That is one point. We want to keep them as well as possible. By any means, we want to save them from hypoglycemic episodes. We don't want to need any kind of a kidney protection, because kidneys are already been affected. Once kidneys are affected, and we don't want that kind of that. We want loose control. What we in our language
But the drug fits into that, sir. It's like driving a car with multiple airbags. And there is more of having a safety part is more when you go for this kind of analogs. And definitely we have seen this kind of discussion in many of the other molecules also. Even we used to discuss like this in with sitagliptin also when it was costlier. Now we are prescribing it to everyone, and the same is for dapagliflozin also. It used to come around 50, 60, 80 rupees a day. Now most of our patients are on these. Yeah, so that is something amazing which has happened, and very soon liraglutide will be off patented. So you will have more experience, the hands-on will be more. So it's the time when we should actually get into the GLP analog kind of story, and definitely we should learn more.
So you know, we at Masterclass we've been very costly, big users of GLP-1 throughout. Must be users of SGLT2, there's no comparison to cost and everything. But we have been big users of GLP-1 from the Biota days. We published our experience on exenatide, then on liraglutide, then on dulaglutide, and now we are compiling our data on semaglutide. So we have found the drugs very useful, of course, in general. But of course, there are issues of cost. Yes. And there are issues of portability. We are there. So it's up to the student.
So Samir, you have the kind of interest you generated for GLP analog and diabetes. I think now is the time to invite the master for GLP analog beyond diabetes, Dr. Amrish Mittal, sir.
Good afternoon, everybody. This is a very different talk from the first one. We're really talking about what's new in GLP-1 in terms of the effects beyond diabetes. You heard Samir very clearly, lucidly, and simply explained it to you in clinical situations in diabetes. But what about their role? Is there something behind the fog, that you can see with GLP-1, which is more than what is actually visible? So GLP-1 RAs have effects on multiple organs. You need not read everything here. It is not very clear slide, but heart and vessels, they clearly have action. Pancreas, of course, we know that. GI tract, we know. They do seem to have action on liver, and they have major action on the brain. This is very important. So they are different from the other molecules we're talking about, which is why their efficacy and their range of benefits or side effects is still being understood. It's not, so there's a whole, because the receptors present in many, many sites, and actions have been shown in many sites. So I think we have to look at it like we started with SGLT2 as anti-diabetic drugs, and actually I think they are nephrology molecules, because they act through the kidney, and all the benefits we're getting are actually because of that, almost all of them. So it became first anti-diabetic, then cardioprotective, then renal, and now without diabetes, renal and everything. So that is how, efficacy was understood first, but the mechanisms were understood later. So there are a lot of different disease pathways. I'm sorry, again, the slide is a bit cluttered, but what we have to see that GLP-1 RAs don't just act through the same insulin glucagon pathway, the normal things that we know about. They act on the liver through a different pathway. They act on, again, the liver, again through another different pathway. They inhibit calcification of human vascular smooth muscle cells through a different pathway. They promote brown adipose genesis. They reduce glomerular extracellular matrix accumulation. They reduce beta cell apoptosis, somebody was asking that, and improve learning and memory capability. Now, these are not all shown in humans as yet. These are all the science areas where you're trying to see, when you see an effect, what pathway is it that is causing it. So this is how this whole field is evolving. So what about GLP-1 RAs and obesity? That's one of the main topics. I will not talk about GLP-1 RAs in atherosclerotic vascular disease or CKD. That's already been done and dusted so many times, and I'm sure the industry itself has explained to you about 1 million times by now. But we will talk about obesity and then move on to neurology, NASH and other areas very quickly. So what about obesity? Firstly, it's still not understood what is the exact mechanism of action, but it is central. So the mechanism of action of weight loss with GLP-1 RAs is central. reduced energy intake. There is only a small increase in metabolic resting rate. People like to have drugs कि मेरा metabolism बढ़ जाए उससे. वो कुछ ज़्यादा होता नहीं है. थोड़ा सा है. There was hope कि इससे होगा, लेकिन it's mainly a symptom effect. And the effect is decreased hunger, decreased cravings, increased satiety. Right? More control over your food yourself. Like you can control your brain better. But not everyone responds. That's the other thing. Some people don't respond. So, very interesting that food choices are influenced. I was talking about energy-dense foods. I found this quite fascinating in the rats and others, and even in some human studies, that people choose healthier foods when they are on GLP-1. Maybe that is simply because they get more bloating and more discomfort after energy-dense foods, but it is shown. Behavioral choices of food do change. Reduction in energy expenditure has been disappointing. Obese subjects have fewer food cravings and resist food craving when they are on semaglutide. And good or bad, you have to take a call, but eating is considered, was found to be less pleasurable for people. One of the pleasures of life you're reducing, but I mean, that's one way of reducing intake. That there was less, they enjoyed food less. This is all published study. And when you look at GLP-1 activation in the brain, it decreases the food reward. We anticipate the joy of having food, that anticipation goes down, that food reward anticipation. And when you consume food, you feel full, that is increased. So actually there are subtle actions on the brain which are determining the impact of these molecules on our eating. And another very interesting thing, they said, why do some people not lose weight of GLP-1? Right? And very interestingly, in the responders they found clearly GLP-1 arrays tagged here and did not reach the brain in the non-responders. Fascinating. That they could actually demonstrate why some people don't respond. So I found this very interesting. The hypothalamic effects of GLP-1 array were seen only in responders. And we don't know what determines this, some genetic difference, or we don't know, but it's been clearly shown. So when we move to semaglutide, we are really talking not of oral semaglutide, we are talking of injectable semaglutide. And suddenly where the pink bars go, just look at those numbers. I mean, that's huge in terms of kilograms. Change in body weight with injectable semaglutide is dramatic. There is no question about that. It is a little less in people with diabetes, for reasons I already explained, multiple drugs, so many things happening. But even then, look at this. We were analyzing our data with oral semaglutide. I think we have close to 400 patients. I don't have the final slides, so I'm not showing that. But weight loss is 3 kilograms, 4 kilograms, that kind of thing. Here we are talking of 10 kilograms in people with diabetes, and without diabetes, 16, 17. So that is massive. Now, why injectable? Why not oral? Because very roughly, these studies are on, very roughly, the dose used is much higher in injectable. So 3 milligram का तो कुछ है ही नहीं, weight पे बहुत ज़्यादा, उतना नहीं जितना हम सोचते होना चाहिए. 7 पे तो start होता है. And the dose they are using is much higher. And if you're not aware, there are studies now with 30 and 50 milligram of oral semaglutide going on right now. So they're to reach the levels, blood levels that they're achieving with the injectable. So that's where it's going. So it's quite fascinating. And then we have amylin analogs, right? And just to put it in perspective, semaglutide, and if you use cagrilintide. Now cagrilintide is an amylin analog. Again, acts on the brain, but different parts of the brain. Right? So very cleverly, the company is doing a trial of combining both the molecules and using them. So if you use them both, if you use semaglutide here alone, up to 17.1% weight loss. Right? That is huge. Cagrilintide, amylin analog, up to 10.8%. And you combine them, you are looking at, hoping to get even higher weight loss. So, quite a fascinating new approach of combining two different molecules. And everyone knows about tirzepatide. Already our Delhi and Bombay patients are obtaining it from Dubai, and I'm sure here too, and using Monjaro, it is called, that's the commercial name, that is tirzepatide, which is GLP-1 and GIP, both. It's an agonist for both. So the weight reduction is look at the weight reduction. We were talking of 15, 17, now we're going that low. So it is quite striking what is happening in this field. And every day there's new research coming out. So this is fantastic stuff in terms of not only long term we know what ultimate tirzepatide is already licensed and available. And I already have 3 or 4 patients on tirzepatide. So again, weekly injectables. Cardiovascular system you are well aware of. I think industry must have told you enough about cardiovascular system and protection. CKD, we don't want to discuss too much. Samir mentioned some things, it's already been discussed. But a direct mode of action like SGLT2 is not there in CKD for GLP-1. It's a different, anti-inflammatory, reduce oxidative stress, general things. There is no real solid action like SGLT2, which are primarily acting through kidney. So there is a difference there. Outcomes we'll see. But overall outcomes have always been favorable, whatever has been done in GLP-1 and kidney. Now there are major studies on, dedicated studies for kidney and GLP-1. So we'll know about that more. But I think one huge area is the neurological area. When the drug is going to the brain and binding to so many things there. So one area, and you can leave this if you like, there are ways to, I'm not an expert in Alzheimer's, but there are ways to do that. There may be people in the audience who are much better than me. Amyloid, tau, and neurodegeneration markers. And if you look at GLP-1, it has an action on all these things in Alzheimer's disease. Okay? So, overall, it started with the mechanism first, because they were curious, but they're finding first in rats and then in humans actual clinical benefits. I'll not bore you with this, because this just shows that different studies have shown benefits of GLP-1 especially in mice. Histological landmarks of Alzheimer's disease were improved with liraglutide. Just that is, you can forget this. Other synaptophysin levels which are depleted are partially restored by liraglutide. Okay? So there's ongoing trials in Alzheimer's disease with GLP-1 RAs. Phase 3, early Alzheimer's disease, semaglutide, and you will find something. Who knows what we'll find? Because the mechanistic, in this case, the mechanistic part is well worked out. If it translates into clinical benefit, we will know probably there is some benefit at least. But the other one, even commoner than Alzheimer's, is Parkinson's in our clinical practice. Not uncommon at all. We are seeing, of course, a lot of Alzheimer's also now. But increasing evidence has demonstrated that GLP-1 analogs in animal models can protect dopaminergic neurons, rescue motor activity, improve cognitive functions in a preclinical trials. So, okay, don't get mixed up. This is patients with moderate Parkinson's disease, exenatide, and they use the MDS-UPDRS exercise scale to evaluate efficacy, and they had better performance than controls. But even in a very broad clinical database setting, compared with other OIDs, prevalence of Parkinson's when using DPP-4 and GLP-1 was half. So there is something there again which may be interesting. We don't know what ultimately turns out. This is a substantial diagram. We can leave this. Again, the mechanism. What about stroke? That is a part of the whole. Now, so much is written about cardiac protection, renal protection, but stroke का तो कुछ ज़्यादा कोई बात नहीं करते हैं. Overall, both are atherosclerotic vasculitis, but data on stroke with any of the other molecules is still not very solid. And we know how bad stroke is, and we know how recurrent it is, and it's a major issue. So again, preclinical studies, and I will leave this. But dulaglutide reduce the incidence of stroke in middle-aged elderly with type 2 diabetes. These are all rats. So what I'm saying is that clearly there seems to be a role of GLP-1 RA in regenerative treatment of patients with chronic stroke, and also a reduced risk of stroke. Now, if you look at the meta-analyses, it's interesting. Actually, meta-analyses have clearly shown, look at the hazard ratio, 0.86, same, has clearly shown that there is reduction in stroke in all the GLP-1 RA studies. So that is also, it's not a huge reduction, but that's the kind of reduction you got in empiric with heart also. So it's not, it could be something very exciting in the future. Again, final answer is not out. dedicated studies are on. And then, of course, when a molecule is popular, then just pain, intestinal pain, irritable bowel syndrome, one study, just pain reduction. And they're good journals. NASH is an area of interest for me, and NASH clearly has shown benefits with GLP-1RA. In fact, we were among the first to show that. First with empagliflozin with SGLT2, and then with bulalutide. And we did show significant reduction in liver fat with GLP-1RA. And therefore, we think that this clearly will be an area, but I don't think that we need to get very excited about it, because I think it's just squeezing out fat from the liver, like from other places. I don't think they have shown any GLP-1 receptor in the liver so far. So I don't think it's a specific action. It's part of the fat reduction in the body. That probably, that's the way. Although, I have to qualify that also, there is some recent data suggesting there might be, at the hepatocyte level, some actions of GLP-1 in the liver also. So tirzepatide, we can ignore that. This is our own study, led by my young colleague Shafi Kuche, and this showed very clearly that you found reduction in liver fat when you used liraglutide for 24 weeks. So the statement you can make with great confidence is there is resolution of steatohepatitis and no worsening of liver fibrosis. यहाँ तक तो आप बोल सकते हैं. Liver fibrosis improve कर रहा है कि नहीं कर रहा, ये अब नहीं बोल सकते. We don't know. So that's where we are. You think it's some kind of a joke, but actually they have found that in pain nobody will come back to you ever. They'll probably take you to court. So I think you start with 3 and then 7 and then 14. Injectable, of course, it is 1.2 and then 2.4. A lot of data on 2.4, the best data. Now 2.4 injectable will be equal to more than 30 of oral, roughly. Okay. So,
a lot of conversion.
Thank you, sir. Thanks a lot for enlightening us with the use of GLP analog beyond diabetes. Thank you. Thanks a lot, sir. Sir has made my job a little bit easy because I'll be skipping up the slides. My job today, as assigned by Dr. Sameer, because he is the one who designed the program, he asked me to talk about the emerging incretins. There is a lot of upgradation in this country, and with the railways also, I'm very fascinated with that Vande Bharat Express. Nowadays, it's one of the fastest trains we have. And it is a kind of train which has got the engine is incorporated in the dabba and engine, dono same. And usually it reaches its destination and the yatri utar jate hain and फिर वो डब्बा फिर से वापस आ जाता है. So this is the concept of GLP receptors is like that Vande Bharat Express, which is very fast. And nowadays they are targeting this GLP receptors by combining it with other molecules. Because जैसा T3 अभी launch हुआ recently in India में भी T3 launch हुआ last masterclass में we discussed about it. The moment you combine this with GLP-1, it is going to be a very good medicine for weight loss. They are trying to combine this with dexamethasone so that dexamethasone will be, आप बोलोगे डॉक्टर स्टेरॉइड क्यों देना? But the moment you give dexamethasone with GLP analog, that Vande Bharat Express will go to those areas of adipose tissue which is causing inflammation, and it will reduce obesity. The same thing they are going to combine this GLP-1 with GIP, that is the twin cretin. And now they have started talking about tricretin. The concept of GLP analog is taking speed now in India and world over. So I'll be talking about the emerging incretins. The current pharmacological armamentarium to manage diabetes, as we have been discussing, we all know, and GLP analog is one of the molecule which is trending now. So the glucocentric approach was to bring down the sugars. But later on we realized we had something more to do with weight. There were joints which were getting killed. Every now and then my patient is complaining about the joint problem, and straight away we said ki osteoarthritis hoga. The moment we get the X-ray, and it is something which is always there. So cardio-glucocentric approach, that we needed that cardio protection also. So that has actually led to the advances of the molecules. And fortunately, in the field of diabetology, now we have got molecules which are being used by nephrologists, which are being used by cardiologists, which are being used. So this is like dropping breaches now. This is what our masterclass is all. We have got people from all fraternity who are attending us. So that is something great, and we need to actually develop these kind of wisdom and these kind of association, because that will take our medical knowledge towards what we actually want to. Because this exclusivity with respect to speciality is not good. So the potential candidate for ideal tool in managing any stage of diabetes is the GLP analog. It increases insulin secretion, decreases glucagon secretion, which will bring down the sugar values, slows gastric emptying, and it is causing satiety. Again, this feeling of hunger is again a problem. And it has got low chances of having hypoglycemia. And with the molecules like tirzepatide, they are claiming HbA1c reduction of around 2.5. That is amazing, which has never been seen before. Even with injectable semaglutide, in some of the studies, it has touched up to 2.4. So weight effect is there, and cardiovascular over the top of it, cardiovascular benefit. So we have got the era of Maruti 800 is gone. Now we have got this cars with multiple airbags, and that ADAG 1 and ADAG 2 system is there. So these molecules are why they are important. Because in future, you will be demanding, you will have demands like this, ki boss, I should have everything incorporated in one molecule. That's why they are relevant. That's why we should discuss about these molecules. Because in days to come, like other molecules, they will become cheaper and more accessible to everyone. So this is how a paradigm change in management of diabetes that has got these anti-diabetic drugs which have got cardiometabolic drugs. Now they say it is cardiometabolic. Glycemic control plus CV protection, focused on reduction of cardiovascular disease along with blood glucose control. This is like driving a car with multiple airbags and multiple systems to avoid any kind of unprecedented events. So this is something phenomenal. The incretin hormones have come a long way from scientific discovery. I always say that majority of the times we hypothesize something, then we make theory, then we bring molecules, and most of the time those molecules are not that effective. But dear friends, this is the magic where they have hypothesized it, they theorized it, and they came up with a DP4 inhibitor, then later on a GLP analog, and these are the blockbuster molecules which has completely redefined the field of diabetology. The acronym incretin, referring to the intestine secretion insulin, was coined by Labarre in 1932. So this is how the science grows. And we all know about the Gila monsters, the Xedin4, and the blah blah kind of story. It's a very interesting story, and you should always, if you are interested, you can see. So how this molecule has evolved from Xedin-based GLP-1 to small subcutaneous molecules like liraglutide, semaglutide. Samir was talking high about dulaglutide, LB-glutide, and the oral semaglutide. Because always, whenever we used to see this fear of injection is always there. Doctor, kuch bhi ho jaye. Injection nahi lagana. This is something which is always there. And irrespective of whatever you do, they come to Dr. Sachin क्योंकि वो injection नहीं लगाते. उन्होंने insulin छुड़वा दी. This is a kind of thing which I usually get as an advantage in my clinical practice. But मैं उनको हमेशा कहता हूँ कि सबसे ज़्यादा insulin लिखने वाला डॉक्टर भी मैं ही हूँ. So this is a hardcore fact. But somehow, somewhere, people they try to associate you with their own demands. So we need to actually tailor-made our prescription as per their needs, and the purpose of HbA1c control has to be there on the top of it. So these are the oral semaglutide, the injectable semaglutide, again the foundation stone for oral GLP-1 analog semaglutide. See, they have played, these Novo people are very good when they play with the molecules, and they try to attach, most of the times their new molecules come like this, they attach a long fatty acid chain somehow somewhere, and they change the structure of this molecule. And this oral semaglutide, they have introduced one SNSE kind of thing, which is again making it accessible orally. Otherwise we had to give injections. So we all know about this. And semaglutide has 94% homology with human GLP-1. So the sustained clinical trial program, this trial I will slip fast because many of the times Sir has also nicely described it. So see with respect to other GLP analogs, exenatide, dulaglutide and liraglutide, the comparison when you see for semaglutide, the sustained data is very promising. Change in body weight, again Sir has shown the slide. It is very significant and it is something very, I will not say significant, it is significant, but it is very promising with respect to the outcome. So summary of the sustain 1 to 5 and 7 to 10 efficacy and safety. So it has got a good number of studies backing the molecule. That oral semaglutide is the first GLP-1 receptor analog in a pill because we always wanted a pill. We were dreaming about an insulin pill also. Unfortunately, the inhalers of insulin could not stand the test of time because of some untoward side effects. But we are still hoping in days to come, what I say, that it helps, this kind of knowledge actually helps me in initiating insulin also. मैं उनको यही कहता हूँ कि आपने कभी सोचा था इतने मॉलिक्यूल्स आएंगे, कभी आपने सोचा था कि आपके पास मोबाइल होगा, स्मार्टफोन होगा. सो द वर्ल्ड इज चेंजिंग वेरी फास्ट. आज आप इंसुलिन ले लो, कल हो सकता है कि you may have something even better and you may not require it to inject. These kind of initiation, ये सब देखिए, वो तो ऐसा है कि बंदर कैसी कुलाटी मारता है सही है. So आज हमने सुबह बहुत लंगूर देखे, तो उसमें क्या है कि वन विहार में काफी लंगूर थे, हम लोग सभी देख रहे थे. बच्चे, जो छोटा बच्चा था वो माँ बाप से ही सीख रहा था और वो उस तरह की कलांटी मार रहा था धीरे धीरे. तो सिनेरियो इज लाइक दिस, यू नीड टू लर्न लाइक दैट स्मॉल किड, जिससे आप एक बड़े लंगूर बने और अपना पेशेंट को, क्योंकि अब समीर ने मुझे ये कहा कि अरे ये लंगूर तो हम दूसरे तरीके से यूज करते हैं. तो अब मैं, व्हेन आई वाज इन ऑल इंडिया, दे यूज टू हायर दिस लंगूर टू टेक केयर ऑफ दोस द रेड माउथ मंकीज. तो जो लाल मुंह वाले बंदर होते थे, दे आर क्रिएटिंग अ लॉट ऑफ पैनिक. तो नॉर्थ इंडिया में ये जो काले मुंह के बंदर हैं, ये जो लंगूर हैं, ये एम्प्लॉय होते हैं, उनकी सैलरी होती है 10 से 15,000 रुपए महीने की. ये पकड़ पकड़ के मारता है उनको और वो भाग जाते हैं फिर. तो सिनेरियो इज लाइक दिस कि व्हेन यू विल इनकॉर्पोरेट दिस काइंड ऑफ नॉलेज, आपको सीखना होगा और यही वही इंसुलिन है आपके इसमें, और उसी तरह से आप प्रैक्टिस में चेंज करके लाएंगे एंड देन यू विल कन्विंस योर पेशेंट. तो आपका ये जो लाल मुंह का बंदर है, जो कि पुअर ग्लाइसेमिक कंट्रोल को रिप्रेजेंट करता है, वो काले मुंह के बंदर को देख के भाग जाएगा एंड पेशेंट विल एक्सेप्ट कि हम ये इंसुलिन के लिए मैं तैयार हूँ. सो यू नीड टू एक्चुअली, आपको ये कोलांटी मारना सीखना पड़ेगा एंड दिस इज समहाउ द सिनेरियो इज. तो द नेक्स्ट जनरेशन इवोल्यूशन, basically the development of oral semaglutide, they have introduced the most effective GLP-1 receptor tested to date is semaglutide, and they have introduced this SNSE as an absorption enhancer, which led to this discovery of oral semaglutide. And the mechanism of absorption of oral semaglutide, I will not take much time. As the tablet erodes, SNSE causes a transient localized increase in the pH, protecting semaglutide from proteolytic degradation. That is a major concern. And that leads to a highly localized absorption of semaglutide across the gastric mucosa in a concentration-dependent manner via effect on transcellular pathways. So the pioneer trials, we've been discussing about this, so I'll not go much in this. They are very, they have actually giving us a very prominent data with respect to the HbA1c control with oral semaglutide. My experience, I have got somewhere around about 200 plus patients on oral semaglutide. Initially, I lost patients because they were lost to follow up. तो कोई भी चीज हो तो उसको गाड़ी चलाना सीखना पड़ता है. तो इनका मैनुअल में they were not very clear, but now what I'm doing is, irrespective of the sugar control, irrespective of the molecule he's on, I go from 3 milligram, I wait for 10 days, then I switch over to 7 if there are no GI symptoms, then I again wait for 10 days, then I switch over to 14 milligram. Initially, the patients who were on liraglutide, they wanted to switch over to oral semaglutide. I started immediately 7 milligram, then 14 milligram. They were the patients who were lost to follow. Some of them, again, डॉक्टर साहब में पुराना इंजेक्शन ही चलेगा, गोली नहीं चाहिए, गोली से बहुत ज़्यादा तकलीफ हो रही है. So this is what I learned in my clinical practice. So now lost to follow, as per the feedback I got from the company people, my patients are the ones who are, I've got the least data with respect to lost to follow up now. Because they are the ones who are continuing semaglutide. Otherwise, clinical practice में आप जब semaglutide लिखते हो, तो majority of the times, lost to follow up, या patient immediately he gives up. कि gases बहुत हो रहे हैं, ऐसी लंबी लंबी gases हो रही हैं सर कि सहन ही नहीं हो रहा. This is what their statement is. So इसके लिए यही है कि आपको patiently इसको चालू करना है. You'll have to wait. You can go for 7 and 14 also, alternate. So there are so many things. तो जो बंदर कुलाटी मारता है वो आपको सीखना पड़ता है. This is something which you don't get from the pharma people. You don't get from the trials also. And this is what we learn when we start prescribing the molecule. And this is what has happened with me in my clinical practice. So the oral semaglutide pioneer summary, I will not go in much detail with this. Superior versus EMPA, CETA and LIRA with respect to HbA1c, weight gain. Again, weight, oral semaglutide versus CETA, LINA, and this it is superior. Cardiovascular safety is there. There is again real world efficacy data. They are taking data from our clinic and very soon they will have this data they are trying to compile. So Indian data will come up. Efficacy was established when given early in the therapy, late in the therapy, and regardless of renal or hepatic impairment. This is the biggest advantage which you have. So the safety summary across pioneer trials is there. And again, expanding the horizon of GLP-1 receptors analog into allied conditions, the many sites of GLP receptors like semaglutide, one molecule, multiple mechanisms, like diabetes, it is helping, cardiovascular disease, it is helping, obesity, chronic kidney disease. Sir has beautifully told us regarding non-alcoholic steatohepatitis and Alzheimer's disease. So the potential benefits, I will skip the slides because Sir has nicely shown us those slides. The mechanism of action in NASH, they say that it is helping with respect to, Sir has nicely told us, it is the squeezing of the fat cells from the liver. It is by that weight loss only, it is helping. So there are so many things. So these are the slides which I'll be skipping because Sir has nicely covered these things. Change in body weight and highly sensitive C-reactive protein with semaglutide. Anything which reduces inflammation will definitely help with respect to highly sensitive C-reactive protein. That is something. And again, if anything is which is causing weight loss, obviously the HSCRP will go down. So now we have got data which is showing it beautifully. And the combined effects of GLP receptor analogs across several mechanisms could be relevant for Alzheimer's disease also. And Sir has nicely covered this. So let me skip this slides for Alzheimer's disease. So the expanding landscape of GLP-1 receptors analogs in allied conditions, obesity, type 2 diabetes, and this. And that was beautifully depicted in the last lecture. So the newer molecules in the pipeline, what are them? So they're combining insulin, the once daily, that is once weekly insulin, icodec, and the basal insulin, which is coming up very soon. Most probably they are going to launch it next year. So they are going to combine it with semaglutide and for better HbA1c, change in fasting, weight gain, and clinically significant hypoglycemia. These are the things which will go down if they will combine it with semaglutide. So this is IcoSema, which we are expecting to come in future. Simplicity, efficacy, and safety. There are two things. Once weekly insulin and semaglutide, both are once weekly. So one shot of injection will help many of our patients in future. And they will say, कि doctor साहब ये रोज का झंझट खत्म हो गया. So that is something will be there for some smaller group of patients, not for all. That is true. Not for all, but for a smaller group of patients, they may be benefited like this in future. So this is once weekly, independent of meals, single pen, simple titration, superior with weight benefit, less risk of hypoglycemia. CagriSema, as Sir had told us regarding this, the combination of cagrilintide with semaglutide, and this is something which is in pipeline, and see the body weight reduction of 15 kgs. Tirzepatide, this is the blockbuster molecule. If it turns out to be, if it extrapolates in what it is showing in trial, it will be a blockbuster molecule, the twincretin, which is going to be approved in India also very soon. GLP-1, GIP, and glucagon, this I was talking about, the triagonist. The GLP, GIP, and GCG triple agonist is conjugated with a human immunoglobulin G Fc fragment via flexible linker. So high glucagon activity designed for liver targeting and NASH treatment. This is improved lipid profile and anti-inflammatory effects of GIP activity. Balanced GLP-1 and GIP action to neutralize hyperglycemia risk of this again is there, and similar in vitro activity. So there are many things which are in pipeline. So dear friends, This GLP-1 should become what Vande Bharat Express has become for India, and should increase our speed to reach our destination of good glycemic control, weight loss, and less of the cardiovascular comorbidity. Thank you. Thanks a lot. The weight is going up, they might they might think of anything which will cause weight loss, anything which will improve the metabolic profile and good glycemic control will definitely help indirectly with respect to the erectile dysfunction you're talking of. Because in clinical practice, when our patient, if he is 100 kg and if he is down by 15 kgs, these kind of complaints, they usually are lessened. I'm not saying they will completely go, but they are lessened. So I have this much of answer right now. So as we do in most of our masterclass, I request you all for a group photograph, and thank you all for coming in huge numbers. We are always having jam-packed halls. So please come for the group photograph, and definitely.
Thank you, sir.
Thank you. Thanks a lot.
बड़ा बंद कर दो।